Good morning. It's good to see so many of you again. Some of you are always here, and I appreciate it. We've had such an interesting discussion, and I think today is going to be very important to the work that we're doing as well. I'm Katie Dempsey. This is all of us that will be here today. Our gentlemen both had conflicts come up, and so they will be catching up online following the meeting, seeing what we talked about today. So we'll be ready for that fifth meeting, which we haven't announced the official date of yet, but I think it's going to also become a little packed with more information, because I think the deeper we go, the more we want to know. So stay tuned. There will be more, without a doubt. If we could start this morning with prayer. And before we do, I want to make everyone aware that Dr. Staplewax had a family emergency come up this morning, and so she's not with us, so I want us to all keep her in our prayers. And yesterday I also did not share with the group, but Commissioner Berry is going through a something with his family as well, so he needs us just to be thoughtful and in prayer for him as well. If y'all would go with me, please. Dear Heavenly Father, we come to you this morning and just ask that you be with us here with the work that is right at our feet right now today, I think, and heavy in our hearts, to try to tackle a problem that can seem so large and so looming, that I think possibly, certainly in your reach, and that we want to help you in that work as well. Open our ears and our hearts and our minds today as we listen to experts and those who have worked so hard in the field to help our youngest little Georgians strive to be the best they can be. Thank you now. Be with us all and give us all traveling mercies. In your name we pray. Amen. Okay. So we have gone through a great series, I think, of work. This is our fourth official meeting, and we began talking about the architecture of the brain, which I think is becoming more and more important as we realize how important those first years, especially that very first year, is in growing the brain. And then the second meeting was on the spectrum of services to look at system-wide approaches and hear from experts. And yesterday we just had, I think, a great day at Chris 180, listening to our child-serving state agencies and hearing some of the work they're doing and hearing some of the dreams and possibilities that they feel we can tackle together in this. And I want to thank, again, Chris 180 for that opportunity. Catherine Bragg, the director there, hosted us along with others, and it was a great day. We're going to try, after possibly early in session, my appropriations subcommittee and then also the members of this committee will do an invitation to go back and actually tour that facility for anyone that would like to, because we worked so hard and long, we didn't really have time to go see exactly where we were, and I think that would be very important to us. So today we're going to talk about workforce, a topic that continues to come up each and every meeting we have, and hear from some great people to work on that whole spectrum that evolves from prevention and intervention and treatment, appropriate diagnosis, all the factors that we know are so important to this conversation. As I said, Dr. Staplewax will not be with us, so we will start off with a return visitor who has already impressed us, but is going to bring us some more information. Dr. Tracy Topple, the Director of Infant and Early Childhood Mental Health Resource of Georgia, part-time instructor at the University of Georgia School of Social Work. She presented during our second meeting and is representing the University of Georgia Social Work School today. Thank you. Good morning. Now, let me make sure I have the podium.
To be here again, and I'm just really happy that we're having this conversation. And thank you for inviting me to return today. As we turn our attention more to, I guess, the nuts and bolts of what this looks like. And I'm hoping to present today a vision of workforce development and how other states have moved forward with this same kind of work and potential opportunities we have here. So just to start off, this comes from 0 to 3, the National Foundation, our national association on all the different sectors that are involved in this kind of work that we've been bringing into the conversation. And so just want to remind us about two big important components of workforce development is cross-agency collaboration and competency levels. And so when we look at all the different organizations and systems that touch children prenatally to early childhood, we're looking at pediatric health care, early care and education, home visiting programs, the judicial system, policies, child welfare, early intervention programs such as Babies Can't Wait that we have here. And all of these programs touch on helping children gain these competency levels in social emotional development. And that's to form the close and secure adult peer relationships, manage a full range of emotions, and explore their environment. So that's what we're talking about. Competencies for really young children is different than working in child and adolescent mental health. And some of that comes in really looking at how the caregiver helps the child to develop these capacities. And so when we think about developing a workforce for really young children, it really does need to be based on competencies that are important for this developmental age. Some of those that have been used across the country have been developed by the state of Michigan, and they're used in roughly over 30 states now and about 3 countries in certain competency levels for professionals working with young children. This is infused throughout the continuum of services. Some of those competencies are core theory, and some of it you've been visiting these past couple of visits and meetings, knowledge, policies and systems, specific relationship-based practice skills for young children, a component of reflective supervision and cultural awareness. Some of those prevention and treatment end models that are part of the competencies are child-parent psychotherapy, parent-child interaction therapy, which we'll hear about today, circle security, and incredible years. So when we think about workforce development, it's about infusing these competencies in these throughout the entire continuum of services for young children. So models for workforce development that have been done, some of them here in our state and across our country. And so I'm just going to lay out 5 different kind of pathways or areas that we could touch on in looking at how that's been done in other states. One of it is an infant and early childhood mental health postgraduate training and workshops for existing programs in our state. That's something that we've already begun to develop in Athens with the Department of Public Health in creating monthly training sessions. We've had 4 now that works towards continuing education units. In our model, we have a total of 10 sessions. We meet monthly. We have about 30 to 40 professionals that are working in different capacities in home visiting that come and hear about different topics in infant early childhood mental health. And it's from observations to assessments to screening tools that they can use, father engagement. So each session has a different topic that would then bolster their work and help to support that work. That's a similar model that's been used in Maryland and Tennessee, which is in Maryland, they've had over 250 professionals trained in the past year on this. They have 10 or 8 sessions to work towards a certificate in infant and early childhood mental health. So that's one way to be able to reach existing programs and practitioners. It could be face-to-face. There's also could be a webinar component to that. Another important piece of workforce development are opportunities for practitioners to receive certification in evidence-based models. And that is crucial that the types of programs and interventions that we're putting out are evidence-based. And there's several out there in this area that we can say have evidence behind them that are effective with parents and young children. Another opportunity would be statewide cross-sector conferences. And currently in the state of North Carolina, they have an annual summit that I think this might be their first year they're running it, and they have taken something that's their home visiting conference, which we have every year here in the state of Georgia, and tacked on one extra day that's just dedicated to infant and early childhood mental health. So those professionals already working in home visiting have an extra opportunity to then to participate in this training. It's a cross-sector collaboration. It's a public-private partnership that they have in their state. The fourth area for workforce development would be a pathway for infant and early childhood mental health consultation. So mental health consultants, you would be able to place someone trained with competency level in mental health within existing programs to provide consultation and observations with children. And this is most effective in early childhood education. We're running that currently in Athens now with the Early Head Start and Head Start programs, where we have a mental health consultant who can provide observations if there are any concerns about a particular child and dynamic in the classroom, work with the family. And so you can provide a basic level of training to all staff and professionals, but then with a particular expertise in one area for consultation. That as well is effective in home visiting programs and really any organization or agency working with children birth to 5. The fifth level of workforce development would be a graduate level training program. And there are a few models around the country, but I really feel like this is an innovative approach to move the field forward. An example there's a program in Southwest College in New Mexico where they have advanced clinical training for master's levels clinicians who can come, it's face-to-face, 1 weekend a month for 4 months to receive a certificate in this type of clinical training with really young children. The University of Minnesota has developed a two-prong approach where they have an academic arm where multiple disciplines can receive a certificate program for academic credit based on whatever, if they're in early childhood education, public health, human development, psychology, as well as an online component where professionals can receive CEUs, and it's based on a course format that they run. At University of Georgia, we have something similar with our nonprofit management program that is out of the School of Social Work, so that for professionals working in the field, they can receive a certificate in this area with continuing education units, or if we have master's level students that are working towards a degree, they can incorporate this as part of their training. What's important about being able to offer something online is we all know the barriers that some of our rural areas in Georgia experience. And so being able to locate material, courses, and offerings in CEU, continuing education units for professionals in these rural areas, I think is a top priority in being able to reach many people. Okay, or practitioners. All right. For the School of Social Work, this is something that we have thought about for some time in infant and early childhood mental health, and thinking about the gaps in our services. We have a large amount of our students that are child welfare Title IV-E students who are going through courses then to graduate to work in child welfare in offices throughout the state. And so we're thinking, how can we incorporate and embed some of this material and this knowledge and these practice skills within our graduate level programs? And so some ideas that we have thought is that we could work within existing structures for CEUs, and that's for universities and colleges, and I think we're going to have another presentation from a college today on ways that we can already incorporate some of this material in existing structures that we have. And certainly incorporating courses specific to infant and early childhood mental health in our child and family clinical courses, as well as our Title IV-E courses. And another opportunity is to be able to provide interns to organizations and programs that are already serving this age with workforce that can be in a learning environment to put some of these practices into place, and then work towards creating an online graduate level and CEU certificate program. We've seen in other states that these have been successful. It is a quite innovative approach that we would have professionals graduating ready to work in this area, which currently is not the norm across the country. So it would be a step forward. So thinking about just workforce development in general, funding comes up. And how do we fund these services, right? And I think it's a conversation that's probably happening across the country. But what some other states have worked towards is looking at how to build sustainable long-term programs. And so thinking about how to finance this, the continuum of infant and early childhood mental health services is important that it be reimbursable for practitioners. And that there are other funding streams to consider, accessing funding streams, federal funding streams, as well as local and state funding streams, or grant programs or foundations. There's also national support systems with 0 to 3 to think about technical assistance and how we might move forward with this. And to be able, states, in order to sustain this funding, have found it helpful to diverse their funds so that it's not all coming from one area in order to survive kind of budget cuts, and as we look forward and for long-term sustainability of these programs. All right. So even in the face of limited resources, by forging new alliances and building on local and state assets that already exist, it is possible to move forward and respond to an arena of child development that has, from a public policy and practice perspective, been too long ignored. And so I'm really happy and glad that we're having this conversation, and I know there are many pathways forward, and I appreciate your attention and your time and dedication that you've given to this topic.
Representative
Thank you.
Oliver.
All of the programs you're discussing are within the School of Social Work. Do you have a growing number of students in these master's level social work? Are you stable? Are you losing students? And how does Georgia compare nationally to this development of this program?
I want to back up and ask, what program are you currently talking about that exists within social work, to be clear?
I'm looking at your letter. It comes from the School of Social Work. So
Yes.
these are all programs that you are offering in addition as part of your graduate program of social work?
So as part of our graduate program, our master's level social work, we receive Title IV-E funding for our child welfare workers. We have child and family mental health clinical classes. However, it's not specifically located in infant and early childhood.
And is the program growing? That's what I'm trying to
Yes, the program is growing, and I cannot quote exact numbers, but I believe that we had around 100 and a little over 100 that graduated in our master's level graduate course this past spring. But yes, our program, I'm not sure how that compares on a national level.
And at some point, since we're talking about workforce, maybe somebody can
Yes.
give us some statewide numbers. There are other graduate social work programs across Georgia.
That is correct. There are other graduate social work programs, and this is not something that that could be in collaboration with other systems as well. This is a model for how university systems or higher education could focus more on this area and infant and early childhood mental health, and certainly could be a collaboration effort.
I'm just assuming this is a growth area for jobs, professional jobs across Georgia.
It certainly
It
is.
is our university system helping, meeting that need. That's what I'm asking.
Mm-hmm. It's something that we definitely see as a need and wanting to help create the workforce that it's ready from day one. Right.
Okay. Thank you. You've given us a lot to think about, but also to reflect upon what is already being done and how we can sort of build that up. And
Yes.
find some better ways, hopefully, to increase.
We have a
the
real
needed.
opportunity in the state of
do.
Georgia because there are many models across the country of how this has been done. So what works for our state? And so we have an opportunity to build that. It's
Thank
exciting.
you. Thank you for sharing that, for the work you're doing
Okay.
every day. It's good to have you back with us.
Thank you.
Thank you. Okay. Our next presenter will be Marianne Chilano, I think is that right? Is that-
Chilano, yes.
Chilano?
Let me see if I
Okay.
can find my presentation.
Right. Professor with the Department of Psychiatry and Behavioral Sciences at Emory School of Medicine, licensed psychologist, board certified in couple and family psychology, interested in behavioral health, workforce development, and health services research, particularly in the treatment of children who have experienced abuse and neglect. She directs the Parent-Child Interaction Therapy program at Emory, and Dr. Chilano is an associate editor of the forthcoming Handbook of Contemporary Family Psychology and a former president of the Society for Family Psychology. Thank you so much for coming to share with us today.
I'm honored to be invited. Thank you so much. I'm a little shorter than the last speaker, so pardon me while I adjust the microphone. There we go. So I'm going to be talking to you today about one evidence-based model for young children. I think the reason I've been asked to come is partly because I know a lot about that one evidence-based model, which is called Parent-Child Interaction Therapy. But I think the other reason I've been asked to come is because I am currently doing behavioral health workforce development in 25 rural Georgia counties funded by a DOJ grant. That's for a different model. That's for trauma-focused CBT. But some of the experience I've had doing workforce development with TFCBT for the last 10 years might be applied to developing PCIT and evidence-based models for younger children. Okay? Representative Dempsey, how much time would you like me to spend discussing PCIT versus dissemination and workforce development?
I think since our first speaker did have a complication, we've got a little more time.
Okay.
So if we see you getting too long, I'll let you know, but I bet it'll work out.
Okay.
Thank you.
Thank you. All right, so I'm going to talk a little bit about PCIT. This is an evidence-based model designed for 2 to 7-year-old kids with disruptive behaviors, ADHD, oppositional defiant disorder, etc. The parent and child are together in treatment. Progression through treatment is contingent on the parent's mastery of criteria. Like all evidence-based treatment for young children, it's based on attachment and social learning theories. And you see the treatment developer there, Sheila Iberg, who's from Florida. The core components of PCIT, like many evidence-based models, are the use of standardized instruments to assess progress. 2 phases of treatment. The first phase builds the warmth and attachment between the parent and the child, and the second phase teaches the parent discipline strategies. The idea, like all evidence-based programs for younger children, is you have to teach belongingness. You have to facilitate attachment and belongingness before you can do discipline, which is why it's always a challenge in foster care situations, right? Because those kids don't really feel like they belong, so it's hard for foster parents to discipline those kids because they don't have that attachment relationship with them. I think what distinguishes PCIT from all other models is that there's live coaching. So I am the therapist, I am a coach, I'm in an observation room looking through a one-way mirror at the parent interacting with the child, and I'm talking to the parent through a bug-in-the-ear device. It's like being a parenting whisperer. And there is homework between sessions. So I like to describe the difference between usual treatment and PCIT like this to potential clients. Usual treatment is try this at home, then come back in a week and tell me how it worked for you. PCIT is try this here and now, and I will help you do it until it works. And I'm with you every step of the way. This is what one of my former PCIT observation rooms looked like. You can see from the observation room, you're looking into the playroom. This is actually from the old GMHI, if anyone's been around long enough to remember, Representative Oliver. And then it was Emory West, and then it became a set for Stranger Things. And if you've seen Stranger Things, you'll recognize the window treatment, which is a nice way of describing the metal bars across the window. That's the playroom. So now I'm in a different place, and I have a different playroom, which I'll show you later. I described the 2 stages of PCIT with their very specific goals. We don't get to PDI until the parents get through CDI, but in PDI, they continue showing warmth and practicing those really strong communication skills, but they learn how to give effective commands, how to implement a timeout, and then slowly we generalize those skills to the home setting and to public settings. I put this up here with some reluctance because it seems to imply that there are 20 sessions in PCIT, but the actual number of sessions depends on the parent. So I've seen families finish treatment in as little as 12 sessions, and I've seen some families take 30 sessions. In my experience, it's somewhere between 15 and 20, depending on lots of factors, including how regularly the parents come, how impaired the child is in terms of cognitive functioning, and so forth. But it generally breaks down like this. There's a teaching session, then there's a lot of coaching till they reach criteria, then there's another teaching session, then there's a lot of coaching, and then they graduate. It is a time-limited treatment. Kids get better. So the pride skills are the skills we teach in the first phase of PCIT. We teach parents to give labeled praises, reflect what their child says, imitate, do parallel play, cooperative play in their child's, imitate essentially what their child is doing with the toys, or participate in a way that the child is leading. Describe is really important, particularly for kids who have problems with language acquisition, and of course enthusiasm. And these are very specific skills that we teach and then coach in a play situation. At the same time, we're telling the parents we don't want to see these skills when they're in this play situation. We don't want to hear commands. The hardest thing to get rid of, especially if you're a teacher or a psychologist, is questions, right? No questions, because that leads the play. And no criticisms. We teach parents to show differential attention, which is ignoring of negative behavior, and labeled praise of positive opposite. So, for example, ignoring when the kid throws the toy at the parent, but when the kid puts the toy in the parent's hand gently or plays with the toys gently, the parent says, I like the way you're playing with the toys really gently right now, right? So we do a lot of that. It's easy, like when I talk about the skills, people go, well, yeah, that's obvious, but it's hard to do with your own child because you're emotionally involved, right? And it goes fast. Like, the kid is playing, you're playing while you're doing all this. This is my current observation room. I now work at Emory Clinic. Since the Grady Child Psychiatry Clinic closed in 2013, I've been reabsorbed into Emory Clinic, and so now I have a PCIT suite there, and that's one of the PCIT therapists I trained. She's in the observation room holding a walkie-talkie because you spend most of the time doing this. You spend very little time with the kid. Most of the time you're talking to the parent. And this is, and that's the playroom, but I'll show you another picture of the playroom later. Technology of PCIT is important. You do need a one-way mirror or the ability to see into another room. You need a microphone in that playroom that amplifies into the observation room. You need a bug-in-the-ear FM device, like the one pictured, which costs $800, or you can do what I've been doing for 10 years, which is use $50 walkie-talkies with a $12 earpiece. I'm hoping to graduate to the $800 system soon. And then you can use video recording of the assessment session for later coding and also giving it to the parent. Here's a video of what your child looked like before we began treatment. And then you should get a video at the end of treatment. You give both to the parents at the end. There is homework in PCIT. It's 5 minutes. So we ask all parents to spend 5 minutes a day, every day, playing with their child and practicing the skills. We ask them to use PCIT-appropriate toys, no screens, no games with rules, no other children present. So that's particularly challenging for parents that have many children, but there's often a way to do just 5 minutes. And of course, the special time, the 5 minutes of special time is discontinued if the child engages in dangerous behavior. The rationale for the homework is that practice helps mastery and it improves the parent-child relationship. It's really an investment in the parent-child relationship. Here are some appropriate toys for PCIT. Going back to the sample course of treatment, let's say the parent has had the CDI teaching session, is practicing the pride skills, has been coached 2, 3, typically they meet criteria to move on after about 3 or 4 CDI sessions. And then we have another teaching session where we talk about discipline. We talk about how to give effective commands, not let's clean up now, okay? Which is broad and indirect and a question posed to the child to which the child could say, no, I don't want to, right? Or we don't want parents to say, I want you to clean up, because that's not really a command, right? That's, well, I don't want to. So we teach parents to say, put the car in the box. Right? Please put the Legos in the box. Right? And then to not engage in chatter, just to wait until the child complies. So there's a very specific algorithm for doing effective commands in PCIT. It's a direct command, it's positive, it's one at a time, it's polite and respectful, and you don't just give your kids commands all the time. You use it when necessary. And if the child complies, you give a labeled praise, and if the child doesn't, they get one warning. That's it. So these parents that come in and say, I have to tell her 40 times to do it. We say at the end of PCIT, you'll be telling her once, and then the second time will be with the warning, and then your child will do it. And it works. We have a timeout chair. There's a backup if the child won't sit in the chair, but it always ends with compliance, because after the child has finished the timeout, the child still has to come back and do the thing that they refused to do, right? And then the parent says fine and gives an immediate follow-up command. When the child does that, the parent gives very enthusiastic label praise and resets the relationship. So the timeout always ends with positive connection between the parent and the child, right? But it is a lengthy, sometimes, and emotionally arousing experience for all involved, including the therapist, because you have to tolerate kids crying and doing other things. Oopsie, I think I messed up in some way. Hold on, here we go. So in the PDI coach sessions, the therapist is initially very active, feeding the parents commands. I literally say, tell him to put this in here. And I direct the entire timeout procedure like the parents are puppets on a string, literally, because that's how close you have to coach just in the PDI phase. But eventually, as the parent experiences success and support, then the parent comes up with more of the commands. And they always try the timeout in the office before they try it at home, because we want them to be supported and confident. There is PDI homework. They practice giving commands. We start slow with play commands, hand me this, give me that. Then we do cleanup commands, and then we gradually progress to put your shoes on, and then what do you do if the kid just swats the brother, right? And there's no command on the table. What do you do for that? We also talk about how to handle your kid in public. This is my PCIT playroom. Notice how barren it is. That's so I can take out and bring in toys that are appropriate for the child. I have a timeout room, which is the backup to the timeout chair, and I can talk more about that if you like. But it's essentially a little room with a Dutch door where the child goes for a minute, plus 5 seconds of quiet, until they're ready to come back to the timeout chair and finish their timeout. Because you have to have a way of teaching kids to sit in the chair, right? So we can talk more about that if you want. The PCIT developers have a position statement on the use of timeout, which we can talk about if you like. But I also just want to talk about assessment for appropriateness for PCIT. So one of the reasons PCIT is hard to learn is there's a coding system that goes with it, because all these skills you're teaching the parents are behaviors that the therapist has to learn to reliably code. What's a labeled praise? What's a direct command versus an indirect command? Things like that. And so you have to learn this system called the DPICS, which is a microanalytic behavioral coding system rather. And PCIT is very data-driven. At the beginning of every single session, you code the parent's behavior for 5 minutes, and based on what you see, you sort of develop your coaching goals for that session. So you can see how PCIT is very tailored to a particular family once you learn the general, treatment. The DPICS requires training, which is why PCIT training is front-loaded, and I'll talk more about that later. The standardized assessment instrument we use regularly, not just pre-post, but every other session, is the ECB, which is a 36-item questionnaire that parents fill out, and we actually track the child's score on that to see if the kid's behaviors are getting better, right? And we review that with the parents. So it's not just a pre-post, it's like every session or every other session, depending on how many ECBs you can afford. So I already talked about this. Okay, so let's just go over research very quickly, because I want to get to dissemination and my experience with PCIT. So findings from outcome studies show improvements for the parent as well as improvements for the child. PCIT has been around a really long time. Okay, Sheila Iberg, who developed the model, I guess 20 or 30 years ago, has now retired. It's in every state pretty much. I mean, there are many, many clinical trials of PCIT. It's so well ingrained now that the new buzz in PCIT is adapting it for other behavioral health conditions than the one for which it was intended. And I'll talk a little bit about that in a minute. But just based on the initial studies, there are improvements for the child, fewer behavior problems, improved compliance with parental commands, improved mood and self-esteem, more flexible, and for the parent, more, they obviously pick up the skills because it's mastery-based. They have to pick up the skills. But they also have increased confidence in their parenting and less parental stress, a greater sense of agency, and a better connection with the child. So the thing that I really like about PCIT is even though it's a dyadic intervention for the parents and one child, the parents take turns, right? Like one's in front of the mirror playing with the child, the other one's next to you, helping you coach, if you have two parents. But the thing I love about PCIT is the gains that the parents make in treatment can be applied to other children, including children that are not yet born. So even though it's an intervention model, you can also conceptualize it as a prevention model. It has been applied to many different cultural groups. This is just a partial list. It's being used all over the world now. Korea, Japan, Europe. It's really just, it's everywhere. The new thing in PCIT is going beyond just disruptive behavior disorders and looking at, how do you do PCIT for kids with separation anxiety disorder or generalized anxiety disorder or comorbid separation anxiety disorder and oppositional behavior? What about depression? What about kids with Down syndrome and fetal alcohol problems? So it's been applied to many different groups. There's a standard kind of procedure you're supposed to go through if you're proposing a modification or an adaptation of PCIT. And there are PCIT conferences every 2 years where they roll out those different, adaptations. I've used it for kids with Down syndrome, ADHD, ODD, anxiety, PTSD, but all of those kids have as a primary presenting problem, they don't listen to the parents or they're running the house. Okay, and you can imagine why that situation would develop. And sometimes it has a lot to do with the kid, and sometimes it has more to do with the parent. Like parents themselves who are struggling with depression. I get a lot of mothers now with postpartum depression. But parents struggling with depression, parents with PTSD, parents who don't have enough support. It's easy to just give your kid the iPhone, right? Or just give in to the kid, which of course reinforces oppositional behavior. So a lot of times you're retraining the parent. And I had one parent say to me halfway through PCIT, wait, this isn't really treatment for my child. It feels like it's more treatment for me, which is in a sense what it is.
Representative Oliver has a question
Sure.
for you.
Forgive me for interrupting.
Sure.
But the issue of postpartum depression seems to be growing in terms of our awareness.
Mm-hmm.
Do you think that there are any accommodations in the workplace for the parents that are being made or thought about or studied right now to help parents in this post or pre-birth time for them in the workplace?
Are you talking about workplace accommodations like increased opportunities to visit with a child, like work-based
Anything like
daycare
that?
or things like that?
Is it allowable sick leave or parent leave to participate in your therapy program? Where do your parents come from to get to you?
Yeah.
And are you paid by insurance or Medicaid?
We're going to get to that.
Okay.
But to answer your first question, I don't know that there are sufficient. I'm not an expert on workplace accommodations. I will tell you this, that many parents with depression will seek treatment for their child before they seek treatment for themselves. And the problem there is, let's say you have a baby and you're depressed. Your child may not show problems that you recognize or that you can seek treatment for until the kid is 5, 6, 7. And by that time, your depression has accumulated a lot of impairment, right? And you've suffered residual and collateral effects of that depression. I think that, some of the referrals I've had straight from like a postpartum depression clinic at Emory, she sends them to me when the kids are 2. So 2 and 3, I get these little kids. And what I notice is that the parents, I need to do a study where I look at their depressive symptoms before and after PCIT, right? Because PCIT isn't meant to treat parental depression. But my personal experience is that the parents feel less depressed as they feel more confident and develop a better relationship with their kids.
Is your work site on the traditional campus, or is it on the Executive Park campus?
So I'm currently at Executive Park, but I did do PCIT at Grady a little bit and at Emory West with Grady patients when I was being trained. And I sort of found a way to see my low-income Medicaid, CMO-based Medicaid patients early on in my PCIT tenure. But currently, because Emory Clinic does not accept CMO-based Medicaid, only fee-for-service,
Right.
which I have feelings about, I don't see those kids now. There's a way to do it, and I can talk more about that later. Yeah.
Forgive me for interrupting.
Yeah.
Is any of the therapy going on in Emory West at this point?
No, Emory West, we all moved to Executive Park.
Okay.
Yeah. Okay, so how does PCIT compare with other parent training programs? And apologies to the University of Georgia folks, I don't have Circle of Security on here, but I do have incredible years in Triple P, which are two of the other big-time evidence-based models. They're all similar. They all use everybody dips from the same well, theoretically, right? They all have homework. They have different formats. Incredible years in Triple P tend to be more group or individual. PCIT is dyadic. The child is there, and you're observing the parent and the child together almost every session. PCIT is unique in that it includes observed practice of the skills you're teaching the parent with the kids. And how long it is depends on the parent's mastery criteria. Okay? But it isn't for everybody. And I put this slide up. This is not a slide you'll see from someone who's like a master trainer in PCIT, because they want to say it works for everybody. But really, in my experience, it's not for every family because it's intense, right? If your child has minimal child behavior problems, but you have a really strong bond, then you're not going to start with PCIT. You're going to get anticipatory guidance from your pediatrician. Then you might go to a therapist who's trained in early childhood and get some parenting consultation, or maybe maybe involve yourself in one of the other parent training programs. But PCIT's sweet spot is a weak parent-child bond and significant child behavior problems. Okay, so think about that. That's foster care, neglect and abuse, right? And kids who have neurodevelopmental conditions like autism and other kinds of things that make them really difficult to deal with. It's also helpful for families with strong bonds but really difficult child behavior problems, and weak bonds but just minimal behavior problems that just send the parent over the edge. So you can imagine a situation where a parent is depressed or unsupported, and the child is maybe not showing really awful behavioral problems, but what they're doing is making the parent react in such a negative way that the child's behavior problems get worse, right? So that's kind of where I see PCIT. Limitations. Okay, so PCIT is really developed for ages 2 to 7. There are older child modifications that really I start using at age 6.5, but it's not really for 8 to 12. I mean, there's been some studies of using it with physically abusive parents where the kids are slightly older, but it's not intended for that population. It's intended for younger kids. The parent and kid must have regular ongoing contact at least 3 times a week to gain the skills. So non-custodial parents, imagine a foster care situation where DFACS is going for family reconciliation and is wanting the child to visit with the parent, the biological parent, who the child will be reuniting with. That child and that biological parent, if it's a young child, should be together at least 3 times a week in order for the parent to practice the skills, right? PCIT requires regular attendance. There's a couple trials that are being published now, I think, that have looked at PCIT via telemedicine. Out of, I think Jonathan Comer is the author. They're doing that in Florida. So that's an option down the road. PCIT requires training and AV equipment. So here are the pros and cons. Pros, it works. Of course it works because you're there till it works, right? It's a mastery-based program, but also it works. PCIT can be tailored to the individual child and family, and I mean culturally, developmentally, in any way, right? The therapist develops a very strong alliance with the parent, and not just with the parent, but also with the co-parenting relationship, because you got one here and one there, and then they switch, right? So you end up improving the co-parenting relationship as well. And I don't mean to be exclusive when I say co-parenting, because I think of that as mother-grandmother as well as mother-father, or any co-parents. Parenting gains generalize to the SIBs. And the other pro is that PCIT has a train the trainers model, which I'll talk about in a minute. The cons, it's expensive. There's the cost of training. There's the cost of the equipment. You have to have frequent sessions weekly. Only one child participates at a time, though many people like me do sibling sessions at the end, because there's no greater test of the parents' parenting than putting them in a room with 2 kids, right? Because that's their life at home. And then making them do the skills, right? And reinforcing them for doing the skills. And the con is it doesn't directly, Representative Oliver, it doesn't directly address parent depression, but I think it indirectly does. Okay, so PCIT, like all these other evidence-based treatment models, have developers that have clarified what the criteria are to be certified, and there's, of course, a website with a searchable database. In order to be certified in PCIT, you have to have a master's degree in a mental health field and ultimately be licensed, though you can do a lot of the training before you get licensed. Requires 40 hours of face-to-face training with a PCIT trainer. There are master trainers at the top. There's level 2 trainers that can train everyone in the state. And there's a level 1 trainer that can train people at your institution, however you define that. I'm a level 1 trainer. In order to be certified, you have to successfully complete 2 cases while you're supervised and master. I mean, it's no surprise that a mastery-based treatment would have mastery-based training. So you have to master a number of different skills, including the coding system. Costs and benefits to an agency. So let's say an agency is asked to pay for this, right? How much does it cost? So I contacted the master trainer that trained me 10 years ago and asked her what she currently charges. And she said it's, $4,500 to $4,900 per clinician for the 40-hour training. Then you have to figure in about $500 for the ECBs, the standardized instrument, because it's $54 for a pack of 25. You want either $100 if you're using walkie-talkies or $800 for your bug-in-the-ear device. And then you have some undetermined cost for video recording capacity in the one-way mirror. So it ain't cheap. The benefits, it's successful. And you can successfully treat child behavior problems, thereby reaching more children. If you have an hour of availability to do PCIT in your schedule, you could get at least three PCIT cases a year seen in that hour, right? So imagine how many you could get seen if you had 20 hours, right? Because it's a short-term treatment. And then if there's a need so a lot of people in this mental health field talk about avoidance of repeated episodes of care, right? And so the way PCIT handles that is, let's say I've graduated a family from PCIT, they call back 6 months later, oh, we're having problems again. So I'll have a booster session. And that usually takes care of whatever the problem is. So you don't have to have a whole repeat episode of care like another 20 weeks, usually. Even families that drop out, which is another issue we'll talk about, but even families that drop out of treatment often benefit because typically when they drop out, they're dropping out after CDI and they've benefited from that first phase. If we had cost-based reimbursement in Georgia, that would be another boon to the agency who invested in training of PCIT therapists. So you're probably wondering how many PCIT therapists we have in Georgia, right? We have 5. We have only 4 that are currently practicing PCIT. We have 3 at Emory, myself and the 2 child psychiatrists I trained. We have a psychologist at CHOA in their feeding program. And we had a psychologist, Dr. Toledano, in private practice, but she just took a job with Skyland Trail and is closing her private practice. So we have 4 certified providers in Georgia. We have 3 others who have gotten some training, but they just have not gotten certified yet, or they don't have the right AV equipment, therefore they haven't gotten certified yet. But to sort of compare, and I'm the only level 1 trainer, and we have no level 2 trainers here. Compare that to other states. Tennessee has 36, South Carolina has 12, Alabama has 6, but 4 of them are trainers, level 2 trainers and a master trainer. So we're not looking good from a PCIT standpoint. So then I thought, well, let me look and see how people fund PCIT. Like, this is if I were you, I'd want to know, how do people fund this? So there is a listserv, and this was a big discussion on the listserv, plus there's other ways of finding out this information through the NCTSN and so forth. So here's a partial list. I'm going to talk about some states in more detail, but you can see Arkansas got a SAMHSA grant and a state appropriation. Louisiana, I'll talk about separately. Michigan uses state allocated funds to improve treatment for fetal alcohol syndrome disorders. Minnesota did something kind of interesting. They have a mental health block grant just for the training costs, and they have a state appropriation for lost productivity time for the clinicians. But if the clinician doesn't get certified, the clinician has to pay the state back for the lost productivity time, which is kind of interesting, right? It's an added incentive to go ahead and get certified, because many people get the training and then never get certified. Tennessee has state funds directed to their centers of excellence for children in state custody, and that's how they got PCIT rolled out. North Carolina is a whole separate story I'll talk about separately. Virginia did it through DBHDD, through the local CSBs in collaboration with the Department of Social Services, and West Virginia uses SAMHSA grants. So let's talk about North Carolina. Now, it's kind of not fair to compare Georgia to North Carolina, because North Carolina has fewer counties, of course, but also they have the National Child Traumatic Stress Center, right? There's 2 in the country. One's in California, one's in North Carolina. So, of course, they have this big infusion from SAMHSA all the time, because that's part of the NCTSN. So in 2006, they developed a child treatment program called within the Center for Child and Family Health, and they disseminated trauma-focused CBT in 22 of 100 counties. So that's what they started. And then in 2013, the General Assembly budgeted an annually occurring appropriation for this child treatment program to develop an EBT infrastructure, which is what a lot of states do. But they focused on child traumatic stress. Their partners were Medicaid, managed care, private sector leadership, et cetera. I'm sure the NCTSN. And they focused on 4 models initially, including PCIT, and they later added another one. Their goal was to develop a statewide roster of trained clinicians and many evidence-based models treating child traumatic stress. By 2018, they had over 800 registered clinicians serving 79 North Carolina counties. They have help. Their Medicaid MCOs offer enhanced reimbursement tied to a specific modifier or service, like the service would be intensive in-home, a modifier would be PCIT. So their rates for TFCBT and PCIT are 40% higher than usual rates, and this, of course, made this a very attractive option for clinicians. Increased costs are offset by reduced repeat episodes of care. This is why the state invested in this. So North Carolina's sitting pretty, but they have a whole infrastructure for EBT. Let's look at Louisiana. So in Louisiana, which is a little bit more like us, I think, initially what they did is they had a professor at Tulane get a SAMHSA grant. This is kind of like what I did with TFCBT, who got some SAMHSA money to fund 2 cohorts of clinicians. So that's 2 groups of probably 8, okay? Then that was successful. So the state of Louisiana provided grant funding for 1 other training, another group of maybe 8 to 10 clinicians. Then in 2018, the Louisiana Office of Behavioral Health worked towards higher insurance reimbursement for EBTs, okay? United Health jumped on board, and they decided to fund a training for therapists on their panel, because now we had enhanced reimbursement. And in the future, LSU is going to be the hub for future training initiatives. So I don't know the details of this, but it looks like the magic combination is some kind of partnership, cost sharing, and some kind of enhanced reimbursement. What are the obstacles to PCIT dissemination in Georgia? I say this from the standpoint of doing workforce development in Georgia. It is a large state. We have 159 counties, many of them rural. How many of you represent a rural county? What county do you represent? Floyd, okay. All right. We have limited behavioral health services, period, in many rural counties. We have counties without child psychiatrists. We have counties with very few people trained to do any child behavioral health. Here's a shocker. How many of you are insured by the University System of Georgia Anthem Blue Cross Blue Shield plan? It does not cover therapy for behavior disorders. It covers medication, but not therapy. I don't know how that's legal, actually. Given the CDC guidelines that say if a child has ADHD and they're under 6, before you prescribe medicine, you should offer behavioral therapy or behavioral parent training. That's standard of care. CDC and the American Academy of Pediatrics, yet we have an insurance system, a rather large one in Georgia, that does not reimburse any kind of therapy for children with behavior disorders. They have to have anxiety or depression, but they can't have ADHD or disruptive behavior disorders. That's a huge obstacle, right? Because the PCIT I offer at Emory Clinic is usually paid by insurance. Fee-for-service, Medicaid will also reimburse it. And go ahead.
Can you explain that to me a little bit more?
Yeah.
'Cause I'm confused here. And let's talk, explain about Medicaid.
Okay.
Medicaid reimbursement for PCIT works how, if it works at all?
Well, now, keep in mind that I haven't been billing Medicaid since the Grady Child Psychiatry Clinic closed. But when I did it, it was billed as, a family therapy procedure code or an individual, depends on how you want to do it. But it's usually family therapy with patient or family therapy without patient, or you can do individual/family therapy. But it was reimbursed.
So family therapy is a Medicaid-approved code for paying for what you do.
Correct. As far as I remember, keeping in mind I haven't actually billed them in a few years. I have billed fee-for-service, traditional Medicaid, like the kid with Down syndrome had that. And I don't know that they pay for family therapy, but you can bill it as the individual/family code, and they paid for it. Most of the people have private insurance that pay, except for this is the first plan I've had that doesn't pay for therapy, any therapy, much less PCIT, for behavior disorders.
And I have no idea how that could comply with EPST requirements.
This is what I'm thinking too. But this is what I've been told by the parents who are educators and looked into it. So again, that's my source of information. Another obstacle in Georgia is we don't have cost-based reimbursement, and I don't know when we're going to get it. Do you? Is that something this panel is able to comment on? Not yet. Okay. We have no level 2 PCIT trainers. So, Alabama has someone who can do it for the whole state. I can only do it for Emory or CHOA, or if I'm in partnership with this other place, I can do it for them, but I can't do it for the whole state. And then a general question, which I think my colleagues at Georgia State or University of Georgia could answer better than I can, is Medicaid well aligned with the requirements of any high-fidelity evidence-based treatment delivery, right? Because when you think about an evidence-based treatment, you have the therapy itself, any coding that you have to do, the instruments that you have to administer, any fidelity procedures, and so sometimes it's more, and I don't know that Medicaid pays proportionally what it should. Does that make sense? So that's a question. However, we have resources. We have Emory. You have people at Emory that have been doing this work for a while. We have the Georgia State Center of Excellence for Children's Behavioral Health. I forgot to mention DBHDD. DBHDD has invested in evidence-based treatment for the state of Georgia historically. Like they funded a TFCBT initiative back in the 2000s. But their current priorities compete with PCIT, just being honest. These are great priorities. Like the Georgia APEX program is a great program, the recovery-oriented cognitive therapy for adolescents, all these are great programs, but they're not little kids, right? It's just different competing priorities. Here are the resources for PCIT dissemination. Child advocacy centers have the AV set up. They have a way to see the child from another room because they're used to doing forensic interviews. We have some folks with grant writing and management experience. Project Launch in Columbus. There's SAMHSA. I currently have a DOJ grant. We have Governor's Office of Children and Families. There's private foundation grants. I mean, there are some potential funding streams. The big question is, what do we do next? Do we go for a federal workforce development grant? I did a search prior to coming here, and I looked for HRSA, SAMHSA. I didn't get a chance to check DOJ yet, but I didn't see anything that really fit. Do we do a state workforce development grant, like a small grant from Governor's Office of Children and Families, which actually funded my PCIT training? Do we push for cost-based reimbursement for all evidence-based treatment in Georgia? Do we look for a General Assembly appropriation like other states have done? Whatever we do, if we bring PCIT to Georgia in a meaningful and systematic way, we should include growing our trainers so that we're not always dependent on a master trainer coming from another state. We should grow trainers within Georgia, like Alabama has and Tennessee has done. And like the last speaker, we should build partnerships. I mean, I think all of this cost sharing is the way to go. That concludes my presentation, but I'm happy to entertain questions about PCIT or the current workforce development I'm doing.
Representative Oliver.
This may be directed to Madam Chair too, but we heard yesterday, I forget the exact number, 8,000 to 10,000 children who are suspended, expelled from child care centers, under 5 years old. Mm-hmm. And obviously, a remedy for that and a way to pay for that for those children and families that are in trouble early in order to prevent an unsuccessful start of K through 12 is our discussion.
Mm-hmm.
So for me to be more fully informed on this, I've really got to understand the funding streams that I've been kind of struggling with. CSBs across the state, there's no CSB service that you are aware of, Community Service Board, that provides this kind of PCIT training to any families or children through any of their networks that you're aware of?
It's easy enough to figure out because there's a searchable database on the PCIT website. So the answer is no, there's nobody. And keep in mind that I do TFCBT training through the with CSBs in the state of Georgia. So I also have that kind of input. And no, there's nobody.
In Babies Can't Wait program, are you aware of any way this particular kind of service or therapy is extended or provided for families under Babies Can't Wait?
I don't. I mean, I get referrals from, I've had referrals from those programs and from the Developmental Progress Clinic at Grady and from foster care situations and from schools, kids who've, failed out of their pre-K program. But I don't know that this PCIT has been integrated in any way into a Babies Can't Wait program.
And I know there's some other similar programs, not exact, but you're not aware of similar programs that are being provided through CSBs or through Babies Can't Wait?
No, and I don't know any other program that does coaching. Like, what would be interesting to do, the ECB is that 36-item questionnaire, right? That's a little expensive, but that's the standard questionnaire that everyone uses, and it's normed for the kids of this age. And so it wouldn't be that hard to integrate that assessment tool into Babies Can't Wait. Claire Coles and her Emory Neurodevelopmental Evaluation Clinic, she's the one that does the assessments of the kids exposed in utero to alcohol and drugs. We've started having her give the ECB as part of her assessment, and I've gotten referrals from her as well. So it's not hard to integrate an assessment tool to identify those kids, but the question is who are you going to refer them to? Right? We have 4 people in the whole state, and they're all in Atlanta. So I feel like we need to train people to do this, and then the challenging thing in workforce development, I'm just going to talk about Thomas County for a minute. I'm doing workforce development in 25 rural counties. One of them is Thomas County, and before I sign someone up to participate in this DOJ-funded behavioral health workforce development, it's like free training. I have to ask them awkward questions like, do you plan to stay in Georgia for the next 2 years? Do you own your own home? I mean, I'm worried about losing them to Tallahassee, quite frankly. That's the problem is I want to invest all this time and money into this rural community, and as soon as they get their license, they move to a city or they move out of Georgia. So that's one of the other challenges in behavioral health workforce development is I want the resources to stay in Georgia. Any other questions?
Yes,
Representative Dickerson.
Thank you for the presentation. Thank you, Chairman. What can you do to incentivize these people to stay in the state of Georgia And why is it that I see that Tennessee has 36 certified therapists? What are they doing that's working so well for them that may work well for us as well? I have another, this is a follow-up to all of this. And while while these students are getting their masters, is there any way we can involve them in this program?
Those are really good questions. Let me address the Tennessee one first. Tennessee, years back, developed the Center of Excellence, and I don't know the details of it other than it was really targeting kids in state custody. So foster kids and kids who are being placed into foster care. You know, some of these things I've heard stories like sometimes there's a lawsuit of, you know, a kid died in foster care, so there's a lawsuit, and then some of that money gets, you know, is seed money for a center, and some states have add to their vice tax. I mean, different states do different things, but somehow they have this center where they, you know, they do cost sharing and they have grant money. I'm sure they get some of their money from SAMHSA because they're part of the National Child Traumatic Stress Network as well, and they make an investment in training PCIT therapists. And then what they do is, again, you don't want to be dependent on people outside your state, so they grow their own trainers, and then their trainers can offer training to people in the state at a reduced cost. You're not dependent on what the master trainers charge, for example. As far as your other question, which was about, remind me?
Okay. Incentivizing those.
Oh, right. Yeah. So the PCIT model, integrating PCIT training into master's and doctoral level programs, right? So a lot of PCIT training does get done in doctoral level programs for psychologists. University of Alabama, Auburn University, God forget, I mean, those are two that you never want to get confused, right? Auburn University, Elizabeth Breston Knight, my master trainer, works there, and she trains her graduate students. And by the time they finish their PhD, they're able to be certified in PCIT. And so I think it's more common to have it integrated into doctoral level psychology programs than it is in master's level social work programs, though there's no reason why you couldn't. That's a great idea.
Thank you.
Any other questions? Thank you very much for your attention.
Thank you. Thank you for the work you are doing and continue to do. Giving us a lot to think about. Okay, our next presenter is Melissa Haberlin. Lane, tell me, how do I say it? Haberlin. I'm so sorry. I should have asked before. Haberlin. The Research and Policy Director for Voices for Georgia's Children. We've heard much, and Voices for Georgia's Children has been very integrated into this assignment that we are working through. But I hope that you will share with us, especially your work as it relates to trauma-informed care.
Excuse me. Yes, and I also wanted to mention, thank you so much for having me here this morning. Prior to moving over to Voices, I was actually at the Center of Excellence for Children's Behavioral Health at Georgia State for a number of years, and also the Health Policy Center there, staffed to the Medicaid team. So I'm well aware of some of the initiatives that they have going on as well. So today I was going to talk to you all about the children's behavioral health workforce from more of a high level. And a lot of this information that I'll be referencing comes from the in-depth analysis that Voices did on the child and adolescent behavioral health workforce in 2017. So I've also provided a copy of the report for you all to have a look at today as well. So I wanted to start off with an illustration of the infant and early childhood workforce that I split into 4 buckets. So we have early care and education providers, such as child care personnel, and preschool teachers who are really helping to ensure the well-being and basic needs of children are met, as well as ensure cognitive development, physical development, and that social and emotional development. And we also have social support providers like social workers and home visitors who help pregnant women, parents and families, particularly those considered at risk, get the resources that they need and learn the skills that they need in order to raise their children in a physically, socially, and emotionally healthy way. Then there are primary healthcare providers like pediatricians that also screen for, diagnose, and treat behavioral health concerns in their patient populations. And then last, we have behavioral healthcare providers whose primary duty it is to screen for, diagnose, and treat behavioral health conditions. So many of the duties of the child-serving providers overlap. So you've heard a little bit about this already, but I wanted to drive home the point about the behavioral health provider shortages that we face in our state. We have 99 mental health care professional shortage areas in the state, which means that in 99 areas, we do not have one psychiatrist per 30,000 people. In 2017, 84 of our counties did not have a psychiatrist. And of our state's practicing psychiatrists, only 53% accept Medicaid and 48% accept new Medicaid patients. And that's an important piece of the conversation because almost half of our children in Georgia are on Medicaid or Peach Care, including some of our most vulnerable child populations, so 100% of children in foster care, 72% of children living at or below the poverty level, and about half of all infants, toddlers, and preschoolers. So as you start drilling down into the behavioral health care provider specialties, the shortages become even more apparent. We have an average of 7.5 child and adolescent psychiatrists per 100,000 children in the state, and that would be considered a severe shortage. So on the right, you can see a map of where all of our child and adolescent psychiatrists are located. And you see that the majority are clustered in the metro Atlanta, Augusta, and Savannah areas. Also interesting, the average age of child and adolescent psychiatrists in our state is 52. So we need to start thinking about how to build this workforce up so that we have enough new practitioners when the others start retiring. In addition to the psychiatry shortages, we also have shortages among some of our other behavioral health care providers. So there are a number of counties without licensed psychologists or licensed social workers. There are 45 counties that have neither. And the bottom line here is basically that we have this behavioral health care provider shortage, and it only gets worse when you drill down into the specialties and subspecialties that are serving children and very young children. So to get into the weeds a little bit more, there are a number of different provider types that would be considered to make up the children's behavioral health workforce. We have child and adolescent psychiatrists. We include pediatricians because more and more they're being asked to perform some of these duties. Psychologists, psychiatric nurses, licensed clinical social workers, licensed practical counselors, and licensed marriage and family therapists, as well as licensed master social workers and associate practical counselors and associate marriage and family therapists. So this chart shows you how many active licenses we had in our state in 2016 for the different children's behavioral health provider types. And in the second column, you can see how many we have per 100,000 children. So some of the big takeaways from this slide are not just to show where we have less members of each of these different specific workforce types, but also to show where the opportunities are. So for instance, we have more licensed counselors and social workers, so we need to be thinking through how we leverage those provider types. Or for the associate level provider types, how do we provide them with the opportunities that they need to attain the next level of practice? The other important piece of this chart to draw your attention to is that, so we do have a good sense of how many students are graduating from our different programs. We know how many active licenses we have in the different areas, and so where they applied for those licenses. But we don't have a great handle on the different kind of specialties or certifications that they hold. So we don't also know where they practice. We don't know what kind of insurance they accept, so whether they accept Medicaid or private insurance, or increasingly how many accept no insurance. We also don't know what kind of patient loads they have, or if they're accepting new patients or retirement plans. So I'm going to jump to some of the most relevant recommendations from the workforce report. The first is that we need better behavioral health workforce data, similar to what we collect for physicians in our state, so that we can better understand what our workforce capacity is to serve infants, toddlers, and older children. And the way that we would recommend to do this is by adding a minimum data set survey to license renewals for psychologists, counselors, social workers, and marriage and family therapists, so that we can answer our behavioral health workforce questions and systematically track them and understand how to grow this workforce in the way that our state needs. Doctors in our state fill out a similar survey when they renew their licenses, and the Georgia Board of Healthcare Workforce publishes the data online. So that's the screenshot that you see here on the slide, where you can really pull up docs by specialty, county, find out average ages, plans to retire, insurance accepted, and more. Second, we have a lot of great educational programs in the state that are turning out master's level behavioral health professionals that could go the full licensed clinical route. But we learned in our report research that a lot of those graduates aren't making it that far because they're unable to get the required supervision hours that they need, because they can't find someone who will agree to take them and supervise them, because the cost is prohibitive. And in some cases, when they are able to get this supervision, it's not necessarily of the quality that they need to set them up for success once they begin practicing on their own. So what we are recommending is that all university programs in the state explore how to play a greater role in connecting their graduates to high quality postgraduate supervision opportunities. We also would recommend that state agencies that operate programs that use children's behavioral health providers, such as the APEX program, would cultivate supervision opportunities through those programs in order to create the greater workforce pipeline. The last point from the report that I'll mention that's already been addressed in some other ways already today is that there's a tremendous need for training and specialization opportunities with the children's behavioral health workforce in particular areas. So there's the need for more providers to be trained in particular evidence-based therapies such as PCIT that we just heard about, or play therapies or applied behavior analysis for children with autism. There's a need for more training in trauma, infant and early childhood generally, suicidality for older children, and administrative skills. And these trainings are not just valuable because they would ensure that patients are receiving high quality services, but it's also really important in keeping providers confident in their abilities and satisfied in their careers and helping to reduce worker turnover, which is another big problem that this workforce faces. So what we recommended in the report is that, and I'm happy to hear that it's already happening a little bit in UGA and certain other areas, is developing programs to fill these gaps and embedding trainings and certification opportunities into their existing educational programs so that the up-and-coming workforce is trained. And that's a recommendation that could apply to all of the different infant and early childhood workforce types. And then the second recommendation is that we would recommend supporting state agencies and provider organizations in continuing to fully develop and scale high priority trainings for their existing workforces. So I wanted to talk a little bit about one particular example of a way that we're approaching this. And this is an endeavor, a trauma training pilot that we're implementing and evaluating currently in partnership with the interagency directors team in DBHDD as a part of the System of Care State Plan. So we're working with 5 schools of social work in the state: UGA, Georgia State, Kennesaw State, Clark Atlanta, and Albany State, And we have developed and embedded a trauma training into their practicum program. So through the pilot, all students that are going into their practicum programs are trained on trauma. In addition, the field supervisors who supervise the students during their practicum are also getting the training. So through the model, the students are able to directly apply their learning into their field experience. And right now, we are tackling the connection to the supervision opportunities that comes next. As well as this year, we're working to develop and pilot a similar program with counseling programs. So this is a good example because, as you can see, it could be easily implemented in other training areas or with other infant and toddler workforce types. Do you all have any questions for us? And I also wanted to call up Erica too, in case you have questions. She is actually the author of the workforce report.
Great. Representative Dickerson.
Thank you for the report. Again, I'm listening to what we need in terms of workforce development and the universities that you're working with. Is it any way that we can incentivize the universities or the state to incentivize these students who are working on their master's in social work to stay here and to go to these rural counties? Because there's a big gap, a large gap in what I saw and where they are and where they need to be. And then in the rural areas, our students in those areas are the students that we really need to work with. And those are our students that I think need that, additional the additional therapy if that's what's needed. Just like they're incentivizing doctors to go to different areas. Can we do something like that?
Yeah, Erica might have more to say on that too, but just immediately, I think that in our thinking about leveraging some of the state programs that currently utilize children's behavioral health provider types, like for instance APEX, that is in all areas of the state currently, and creating those supervision opportunities for students who have graduated to practice in those areas, that's an opportunity to sort of keep them there, get them engaged, and hopefully allow them to stay in those areas. Did you want to add?
Yeah, I think in addition to what Melissa said, three main things that we've been looking at. One is growing the workforce from those existing communities. Mm-hmm. Albany State has a master's level social work program, and they, over the past year, have completely overhauled it in a way that they are trying to cultivate those from that community to become students in the program, and then through that are creating the supervision, continuing education units, making it very easy for people to stay there because they're getting access to all they need to get their license, maintain their license, and create a community of practice there where they've got their support. I think one of the things that we heard from rural providers and leading and talking with folks around the state for the report is that they're alone, like they're the sole provider there, and that's a lot of pressure. It makes it very hard to practice when you don't have a community of other practitioners to support when you're dealing with some really challenging issues in families. The other thing, and this was brought up before, is that you're able to support yourself and your business, your practice, and the ability to have a salary or to get reimbursement for those services at a rate that helps you pay back your student loans and support your livelihood has been challenging. And so one of the recommendations in our report also asks Georgia to look into that enhanced reimbursement rate that was raised as a recommendation before, that if you go through the training and you have that expertise, that you're reimbursed at a rate that is aligned with that. And the third thing I'd say is looking at paraprofessional workforce. So those that may not have an advanced degree, but that can help support and augment professionals that have that, like registered behavior technicians that are often used in autism treatment and now being used even beyond that. So looking at the technical colleges and how they can play a role in supporting a workforce in communities that can augment the very small clinically licensed workforce.
Thank you.
Any other questions? Okay. That was,
Thank you.
thank you so much. Thank you. That's an excellent report that I know we'll use as we come to the end of this opportunity that we have here. Okay. Our next presenter is Ellen Reynolds with Georgia Child Care Association. Ellen, it's good to see you here. It was good to see you yesterday, too. Hope that you'll share a little background about the Georgia Child Care Association and introduce the speakers that will follow you. Oh, let me switch to
You see, I brought the rock star with me who
Thank you.
has
Thank you.
a fan
Thank
base. I am Ellen Reynolds. I'm the executive director of the Georgia Child Care Association, and we represent the 3,200 licensed child care providers, specifically the owners and directors of child care programs across the state. Londi Okenorn Meadows is one of our shining examples. She is the vice president of our legislative committee on the board and does an outstanding job for the work she does in Clayton County. Just to give you a little background, we are very fortunate that our regulatory agency is a valued partner with us, DECAL. In 2017, what we started hearing from our workforce is that they really are craving training around challenging behaviors and inclusion. Particularly when you're dealing with young children, 0 to 5, when you identify developmental delays or deficits that might need to be addressed, there's a real challenge sometimes around getting parents to embrace the fact that a child may have some issues that need to be addressed. I even saw it with my own sibling and his son who's on the autism spectrum, and it took them till he was probably in 3rd grade before they could really address it. So I think we see that a lot across child care programs where we are working, and when you asked the question yesterday of where's the place to start, and someone said the hospital, and someone sitting behind me said even prenatal, which I agree with, but I think child care programs can be an invaluable partner in working on these issues with children and families, because there are things you can do in the child care setting, even if the family's a little bit reluctant, there's still things you can do to work with the child and then hopefully bring those families along. But what we started hearing from our workforce, and this has been a really challenging time for child care providers. I've represented them for 20 years, and this has been the most difficult time in terms of workforce shortage that I've ever experienced in working with them, because you have such a robust economy, so there are less people that are available even as an applicant pool. Then on top of that, you have people that can go work at Target or Walmart for $11 to $15 an hour and don't have to go through a background check that includes getting a background check in every state in which you've lived in the last 5 years, which is now the federal law of the land. So it's been a really challenging time in terms of recruiting workforce. And we appreciate one of the things that we asked DECAL to do, 2 things that we asked DECAL to do that they did with the additional dollars they received from the CCDBG and CCDF funding was, one was to pay for background checks for the state and federal background check, which is $50 per employee. That's been running them about $250,000 a month. To tell you what the impact of that has been to the workforce. That is the amount of turnover we have in the child care industry. That doesn't include the background checks that they have to go get from other states in which they've lived. That just includes Georgia and the federal and our National Sex Offender Registry, State Sex Offender Registry, and Child Abuse Registry. $250,000 a month.
And where's that money coming from? You gave some initials.
I'm sorry, it's in the Child Care Development Block Grant reauthorization in 2014. That's where they mandated the background checks. And Liz, am I correct? In 2018, she stepped out. I believe in July 1, 2018 is when they got an additional almost $90 million for Georgia. It was a tremendous. They doubled basically the funding that was in the Child Care Development Fund, CCDF, and so that's where the funding has come from, and they've done great things with that funding. I frequently say I believe DeKalb is one of the best run agencies in all of state government. They really are, as a licensing agency, efficient, as friendly as they can be while still maintaining that arm's length transaction and governing child care centers. So they did that, and they also retained incentives that they had originally gotten through a Race to the Top grant to continue rewarding teachers as they progress in their credentials and degrees, so that it incentivizes our teachers and our workforce to continue their education and keep moving up all the way through the master's level. So we very much appreciate the work that they have done to try to help us with our workforce issues. That being said, just a couple other points I kind of wanted to make. I've heard some conversation around we need to get 3-year-olds or services to 3-year-olds in all 180 public school systems. The way child care funding works, infant and toddlers don't pay for themselves. You have to have 3 and 4-year-olds in a child care setting with the ratios that are larger for 3 and 4-year-olds to pay for infant and toddler care. So if you end up putting 3-year-olds in public schools, you will end up decimating infant and toddler care because it will just cease to exist. So you'll end up having children who show up at age 3 to public school who have not had the benefit of quality child care programs in infant and toddler. And I think that's something that's not often well understood. Also, another thing to understand about public schools is there's an attorney general opinion on point that says one state agency cannot regulate another. So all these school systems that are starting their own early childhood programs are not, most of them are not working with DeKalb. They're not following their standards, they're not following their rules, they're not following their curriculum, they're not following any of that. So if we were to move to that model, there would need to be something that addressed, really the rules don't contemplate even 4-year-olds or barely 5-year-olds. The rules really are designed for sequential learning, first grade and up. Maria Montessori, who founded the Montessori movement, did a lot of great research and work around the fact that the way children learn from 0 to 5 is experiential and through play. It's not sequential learning. So sometimes what happens when you get 0 to 5-year-olds in a public school setting is that they're expected to sit in seats and try to do sequential learning, but that's not how children learn at that age. So there is a real reason why you have a separate regulatory agency with a lot of expertise that's a leader in the nation, and we need to think about those things when we think about combining, and there's a lot that could be done to enhance services coming through public schools to work with work in a child care setting. With that being said, I'm going to turn it over to you to let you sort of talk about what you experience as a child care provider in Clayton County.
Like you said, my name is Wanda Okanora Meadows. I'm with Little Ones Learning Center. I'm a 3-star quality rated center. And as you know, Clayton County has the lowest child well-being index in the county.
Can I ask you to pause just a minute? I think we have a question.
Oh, yes.
Representative
I'm sorry.
Oliver.
How many school systems have early child care centers now out of the 180?
I don't know a
Decatur,
definitive
Atlanta.
answer to that. Decatur, Atlanta, there are other school systems that are looking into it and getting ready to start it.
Marietta has one too.
Okay. There may be some in rural areas that I'm not familiar with. I know Clayton County is looking at starting it and putting all 3-year-olds in, and Wanda can speak to her experience there.
So as you know, Clayton County has the lowest child well-being index out of all the metro Atlanta counties, according to the United Way Child Well-Being Index. And I want to thank you for allowing me to be here. A lot of times we have policymakers and people that want to make decisions for us without including us. So I am grateful to sit here and just speak about my experience as a child care provider in the county. So just with workforce developments, we are not glorified babysitters. And one of my pet peeves is when people say, you know, what daycare do you go to? I'm like, we're not a babysitting service. I have a dog and I take my dog to a doggy daycare. We don't just let our kids run around aimlessly for hours just without any kind of structure. So that's one of the great things that DECAL and many of us advocates and allies have tried to change the language and the terminology, that we're early educational programs or we're preschools. We appreciate our staff. So if we know that with 0 through 5, that is one of the most critical years, that we should make those investments. And I think just the fact that we're here on the study committee here, that speaks volumes. And that's where those investments should be made. And if we know that, this is where we are the most underpaid workers, the least investments are made. There's just no reason that our Georgia pre-K teachers are working 2 jobs. I have teachers that work for me 8 hours a day, and then they go to work at Walmart to do that second shift, and yet I expect them, or we all expect them, or teachers expect, or parents expect them to, put on their A game on Tuesday morning, and the rat race continues day after day. So I don't know what the answer is or the solution is, but I'm just asking to be cognizant and aware of that, and not put Band-Aid fixtures, paying teachers at the K through 12 age. There is a disparity in income with that, and we have the highest turnover rate in the industry. So the population that I serve is, a lot of my parents are, or my families are, they receive subsidies. They're single parents. We have a high population in families that are on caps. They get help from the state. And if we just try to look at things, if we apply the equity lens, if we know that my population or our population in Clayton County, they do need the most services, then we should have the teachers that need or have the highest training and services for these people, have the highest quality of care. So with that, we know that hurt people hurt other people, that we hear that phrase all the time. A lot of times people think that, your teacher should understand how to work with these populations of of children because they're brown, they have this equity lens, right? No, they don't. They don't understand ACEs or adverse childhood experiences. They don't know. Just because, I always tell people, proximity does not equal understanding. Meaning just because my teachers are African American does not mean that they understand how to deal with toxic stresses. It doesn't mean that they understand how to deal with, as voices advocates, does not mean they understand how to deal with their own trauma. A lot of the teachers, they don't even know that they're dealing with trauma. So just investing in understanding how to deal with that population, not deal with, wrong phrase, how to work with that population and have that training would be a lot of help. I don't think even my teachers, I'm going to be very, very transparent here. I walk through my own hallways as a 3-star center, as being NACE accredited, as knowing that we try our best to deliver the best farm to early care. We have an awesome farm stand. Voices is a partner with me on that initiative. We have Kellogg funding. I work with United Way. I work with Food Well Alliance. I work with every kind of partner. I am a bleed every kind of organization that's out there. Why? Because we don't have it. I don't have the luxury of being in Johns Creek and everywhere else. I have to work with as many partners as we can to get the same kind of quality services as other organizations that are out there. But I walk through the hallways of my own center and I hear and see my own teachers calling out the same kids over and over again. And sometimes those kids are doing nothing wrong, but they're just so used to calling out the same brown boy that's overweight. If you look at the studies, brown boys get called out more than your little nice girls. That's just the studies, because our kids don't, or I don't believe that teachers understand their own implicit biases that exist. So if they're not trained on dealing or recognizing their own implicit biases, then we have this terrible pre-K to prison pipeline. I hear my own colleagues suspending 2-year-olds. There's something wrong with that because they're biting. Why are they biting? Because we haven't given them language, how to talk how to relate, how to express their feelings. DeKalb has this awesome program called PBIS, which stands for Positive Behavior Interventions and Supports. And I was thankful enough to be, or fortunate enough to be part of that pilot a couple of years ago. I wish every program could have been part of that, because through that it taught me, even as a parent, we don't need to be teaching kids to say, I'm sorry. I was taught to say, I'm sorry. Just say you're sorry and you can go back out on the playground. But why don't we teach boys to say, I'm sorry? Because they don't mean it. I would teach my own child, say you're sorry. Well, that I learned, my own son, he wasn't sorry for hitting his sister on the head. He meant to hit his sister on the head, right? So if we're telling our children, say you're sorry, we're teaching them from an early age to make empty promises and not recognizing how to develop empathy and recognize and just give them different kinds of vocabulary. So, and then later on, I don't want my own son 15 years down the line telling a woman he loves her, and he really doesn't love her, right? He's just trying to just do whatever. I don't mean do whatever, but but just recognizing those feelings. So just dealing, having that awesome program with PBIS, Positive Behavior Interventions and Supports, was really, really helpful. One of the things also with that I would recommend with the investment in training, and Voices just talked about that with their mental health department, is we now have a no expulsion policy, which means if you enter Little One's Learning Center, you will never get kicked out, period. From 0 through 5 through 12, we're not putting any child out. Because there's always ways we will try to work, even if we have to do a modified day program. Anything we can, we're gonna work with therapists, we're gonna work over and over and over again. We have lost teachers because of that. I recognize that, which means we gotta find some funding to find some kind of way to do some, build a stress classroom, get some yoga therapy, something to get our teachers just breathing space, rooms, something so that we can make sure that our teachers are mentally well, because just as much as we invest in our children, I want our teachers to also know that they are special, we're going to take care of their mental health. They need time away. But we're not going to start putting 2-year-olds and 3-year-olds out of our program and putting them on that pre-K to prison pipeline, because we know what the studies show. As soon as you start putting them out now, because what's going to happen, those parents, they're not going to do anything with them anyway, but take them to the movie, get them a new pair of tennis shoes, and they're going to be right back in my center tomorrow doing the same darn thing. We need to be in the centers teaching these kids the skills that they need to learn how to use their language, learn how to identify with their feelings, and not peel the paint off my walls and put them in the corner. Put them in the corner, that's what they're going to do. They're going to peel the paint off my walls. And so investing in leadership, a lot of times we talk about, oh, the teachers need to do this, the teachers need to do that. No, I need the state, I need DeKalb, I need Voices, I need United Way, I need everybody to also help invest in leadership. Leadership falls from the top down. So if we're investing in the teachers, but we don't have the leadership, meaning owners, administrators, directors, also having that same training that the teachers have, then it's kind of sort of like a broken pipeline. So I don't know what that looks like. There's people a lot smarter that can help figure that out, but that's just something that I would like to, because I don't like sitting at round tables and I'm hearing peers talk about, yeah, I had to put this 3-year-old out. That's not okay. And also, I want to strongly recommend just thinking outside the box. So like I said, Voices is a partner with Farm to Early Care and Learning. There's also other ways other than books and computers and ways to teach empathy. Kids need to get out in the dirt. They need to get out in the dirt. So just funding, investing in funding, playing with the fingers, getting out in the dirt. It's also when I walk outside and, the kids are no longer trying to, play that, I'm squishing up a baby bumblebee, won't my mama be so proud of me? No, they want to carry a worm and, put it in its new habitat. They want to try to put the worm in their pocket and take it home, and it's all smushed up by the time they get to the front door. There's something about being outside with nature that teaches a kid how to start investing and taking care of soil. That becomes their new focus. So just lots of awesome creative ways, and I believe the farm and soil and nature are an awesome way to do that.
And one other thing I neglected to mention is DeKalb, with their 18 inclusion specialists, they have 6 behavior specialists and 12 inclusion specialists, and that's an expansion that began July 1. We're very appreciative of that. Again, I think they're a leader in the country on looking at infant and toddler and young child mental health and trying to figure out the supports that children need. They're also great they make evidence-based, data-driven decisions, and so part of this is gathering the data so that we can then determine what solutions we need to move forward. But in 2014, there was an economic impact study that evaluated there were 330,000 children in licensed child care settings in Georgia. So you're talking with 18 specialists, 6 of which are only dedicated to behavior, that's 18,000 children per specialist. So that's something that we would love to see increased funding for, so that there are more robust resources for programs and for children and families. So, any questions?
Representative Oliver or Dickerson? I can't tell which number
Dickerson.
to have. Dickerson, sorry, Representative Dickerson.
Thank you for the presentation. And since you guys brought this up, we did hear from DeKalb on yesterday, and I just have something to say that they talked about the 3 Bs yesterday, and I hear you talk about the brown kids today. And I was disturbed by the acronyms that were used yesterday, and I did address it and hope that, I told DeKalb I'll help them come up with a better acronym, because I don't want our kids to be stereotyped, and I don't think that they should be. And I think that starting with the PBIS is good, because no child at 2 or 3 should be expelled from school, because I went home and I slept on this, and I couldn't even sleep because I was thinking about it.
Oh, good.
Because it really did disturb me after I thought about it, and I didn't have as much to say as I thought about it even more on yesterday. But it did disturb me a little bit.
With the big brown boys?
No, it wasn't big brown boys.
okay.
It was black big boys. That's what she said. That was trending.
Oh.
And I understand, she said it was because of minority. They were tracking minorities. And if they are, that's fine, but I still think that we can use a better acronym than that. And I listened to you just now, and you talk about that. And I hear that you say you don't expel your kids, which is great, because there's more to it than that. We have to understand the culture as well. And I think that there is more to these kids than this bad behavior, like they talked about. There may be things at home that's going on with them that we know nothing about. It could be not enough food,
Yes.
the parents, just
Yes.
anything that they're getting from home that's making them act this way.
Yes.
So I just hope that we do a better job in describing, these kids, a description, because like I said, I was very disturbed by it. And to hear it again this morning, it's just bringing up even more of my
Triggers.
feelings,
Yeah.
as to why we need to, do better.
Yes.
Thank you.
Well taken, thank you.
Representative Oliver.
These 6 or 18 inclusion workers that DeKalb has employed, what do they actually do? How do they respond?
Well, they've developed, as Susan Adams mentioned yesterday, they've developed a 1-800 line so that they can triage, and it goes kind of in that pyramid where 80% of the children can be managed in a classroom just fine, and there's another 15% that need a little more individualized attention from the teacher, and then there's a good 5% that need a lot more specialized treatment. So what they're trying to do is help triage, and it's the first of its kind. It just started in July. They're trying to help find interventions and supports for children and the families and the child care teacher, owner, director, wherever that is needed, to get them supports in their area. There are resources DeKalb can leverage that as an individual child care program, a child care program can't. And so that's the kind of work, I don't know if that's specific enough, but that's the kind of work that they're doing.
I remember the discussion yesterday, and that it was very, very new. It'd be helpful to see how much it's working and how different interventions are working, because for most of the 3,200 licensed agencies, they're not going to have access to Emory University
Exactly. And so this is a start, and we all recognize, DECAL recognizes it's a start, but you have to start somewhere. And so that was one of the things they chose to do. And it was something that we had recommended, and I think, Voices and Gears, a lot of folks recommended, but they do with the additional dollars that came in through the Child Care Development Fund and the Child Care Development Block Grant.
It'll be interesting how that's going. They'll be able to, industry, how they think it's going, how DECAL think it's going. That's
I can tell you the
promising,
industry is so welcoming it and so grateful for it and grateful that they're starting down this path, because there just really hasn't been before it was kind of fractured, and now as of July 1st, when you have the 1-800 number that you start with, you have a starting point that everybody goes to now. So it's centralized in a good way. Sometimes we hear centralized, it's a bad thing. This is centralized in a very good way, so that they can triage. You've got knowledgeable people that are answering the phone that can direct you to resources in your area or go find them in the area. So that's to me a significant development as of July 1, that they had some inclusion specialists before that, but it wasn't this intentional centralized where we're triaging families. So that's an improvement that's already been made over the work they were doing the previous year.
Well, thank you so much. I think that takes care of our questions. Thank you for the lives you're touching every day, and Ellen for the work that you do to make sure that they are supported.
Thank
So,
you for the opportunity.
Appreciate it. Sure.
Wendy would like to ask you a question.
You can try.
Representative Dickerson, thank you so much for pointing that out. I just wanted, is there a different word that you could?
I'm coming up with one.
Okay. Okay.
I'm gonna find something for you.
Because I'm one of those, I'm so passionate about that equity and making sure that the labeling, the stereotypes, and that's something that I focus my life on. So.
And honestly, it's coming out of a federal office on minorities is where this is coming from, and it's how they've tracked the research. But I heard you yesterday. I did not give her your thoughts ahead of time, so my apologies. I know
It's
you
okay,
could
because you know
back the
how I
bus
feel
over
about
there. Yes,
my
exactly.
language.
Yes.
Very.
And that's fine, because when I asked her about the federal thing, she said, no, it was just a Georgia. When I talked to her, okay, well, it's a federal
It's a federal.
as well as Georgia. Is that
No,
correct?
it's really not Georgia. It is really a federal
She said it was
thing.
trending in Georgia. Is that correct?
Trending in Georgia.
That's what I thought I heard. I may be corrected.
What I heard Susan say was that she wanted to set a new label, trending, but no, it's
Okay,
it's,
if you can get me, I would like to just hear exactly what she said, because if I'm wrong, I'm wrong, and I don't mind being wrong, but I still just think that even if it's trending, and that's what I think I heard.
I think what I heard her say, this may not be accurate, what I heard her say was that is how the data trends are identified, not trending in the hashtag term, but that's how data trends are identified, if that distinction makes sense. Not that it validates the term, but I think what she was saying is that's how research generally has identified.
Okay.
So not that DECAL was identifying it that way, that it's come out of the federal office on minorities. That's how they were saying these children are being singled out and over-disciplined, over-suspended, over-expelled.
Like these categories
Yes.
of children.
Okay. Well, it was still kind of disturbing.
I understand completely, and I'm with you on finding a different way to talk about that. I think we all are, and appreciate you bringing that to the community's attention.
Okay, thank you.
I think it's important how we take that, those terms, as you're saying, because Representative Dickerson and I talked about it again yesterday afternoon too, and make sure exactly what the intention is. I understand I do a lot of work with obesity as well, and so understanding that sometimes, though, our larger children are presumed to be older than they are, and that's historic. That's always so. Your expectations are increased. That this child should behave in an older way when maybe they are not that age yet and do not have those skills. So I think, as I heard it, that was kind of what I was hearing, and that it does seem to be. Perhaps it is for, and maybe there's a way to clarify that it's actually always those big, older looking children tend to trend that way, but then more so is being seen in the particular population of the
African-American community.
Oh, let me put you on right there.
The African-American community, which they're tending to stereotype again. And I think it's it's unnecessary, because then our kids they're going to feel this. Children feel everything and they hear everything, and we don't want them to start feeling like they're the worst kids in the world. Even when I think about the terrible twos, I don't think they're terrible anymore.
Exactly. Right. It's just it's a growth phase.
It is.
And I think the 3 B's were intended to call our own bias and our own to check ourselves in the early childhood education community on, am I being cognizant?
The implicit bias, and I have the report. I have a it's a study from 3 years ago where the researchers found that they did a study of specifically early childhood providers, and this is what they found, that the teachers were I don't know if they were aware or not aware, but they were finding that teachers were calling out behaviors more so with this population of children.
But it could be other populations that they haven't even collected the data on as well.
I'll have to go back and look at the study, but I'm happy to get it to you.
No, I
Ellen.
think that's kind of what the study was saying, is that this is specifically the population that is over-disciplined, over-suspended, and over-expelled.
Inappropriately.
It was inappropriately.
Inappropriately.
It was inappropriately. So
Yes.
calling awareness to that bias.
It was proof of discrimination against those children.
Yes.
That's what the study was about.
Absolutely.
This isn't saying these children are the bad children.
No,
This is
no.
saying This study proves that these children are being discriminated against and harmed in
The
these
same behaviors
classes.
were observed in non-brown children, and the non-brown children were not punished.
It's not proof they're bad. It's
No,
proof
no,
that
no,
we
no.
as an
Right.
institution
Yes,
are
yes.
inappropriately
Yes.
Have a bias.
treating this group of children differently and wrongly as opposed to this.
Absolutely. That's exactly what the study showed.
Right.
Absolutely.
Thank you.
So the intent of that is probably something that we need clarified for the purpose of this committee. I would say the intent of that, there's probably some language that's very specific to that explains why, after the study, these facts were found to be the specific statistics, not to brand in any way, but probably to increase awareness, perhaps, and sensitivity to
try to
create
reverse that trend.
fairness.
Yeah.
Right, yeah. So maybe if y'all can find that, if anyone can find the language of that study
Yes,
and what the purpose of it is, that it would probably just clarify. And you can get it to us, and that might help. Yeah.
Absolutely.
Yeah. Thank you so much. Thank you. Mhm. Okay, so next, I believe we have Marcy Smith, the Dean of the Business and Technical Studies at Chattahoochee Technical College, and Tamika Brundage, the Early Care Instructor at Chattahoochee Technical College as well. And y'all are welcome to present wherever you're more comfortable. I know if you're working from there, that's great. Chattahoochee Tech offers both certificates and degrees in early child care and education. Marcy Smith and Tamika Brundage, we hope that you will discuss the ways that your specific program addresses the social, emotional needs of infants and toddlers with future early childhood educators. Thank you.
Thank you very much. Can you hear me? Okay, can you hear me? Okay, that's better. Thank you very much for having us. We're very pleased to have the opportunity to talk to you about the piece of workforce development in early childhood care and education that we hold. And as we go through this presentation, when we're talking about we're talking about the Technical College System of Georgia. We are specifically from Chattahoochee Technical College, one of the 22 technical colleges. But there are a lot of things that I've heard here this morning already that in my mind seem like a good match for what the technical college system does and the ways that we work to prepare caregivers and teachers who are working with Georgia's youngest children. So I'm going to talk to you specifically about what the technical college system does for preparation for the workforce in in early childhood care and education. And then Tamika is going to speak more specifically to infant and toddler social emotional development, as well as the competencies and what our students are learning in our programs. Okay, so Across the state, Technical College System of Georgia offers early childhood care and education programs, and that's what our programs are called. There are a variety of them, and we'll talk about those in a minute, but the goal of our programs, all of them, that umbrella, is to prepare individuals to provide quality care for children in Georgia. The focus of all of our programs is birth through age 5. So we're not training teachers to go into elementary schools specifically, although there's a lot that you can learn, that's good practices with children no matter what their age. But our focus is specifically birth to 5, okay? We offer an associate degree. The 2-year associate degree is the longest credential that the Technical College System of Georgia awards. That's a 67 credit hour, and that doesn't really matter. It's an academic distinction, but it's a 67-hour associate degree. We offer a diploma, which we typically call a 1-year program that takes students about a year to complete. And then we offer 9 technical certificates of credit, and those are our shorter programs. Students can come in and complete those in as little as 1 semester, sometimes 2 semesters. It really depends. I want to call your attention to that number 9. Technical certificates of credit. A few years ago, that number was 8. So one thing I want you to understand is that our curriculum can evolve and can change. We had a college that took on and added an additional certificate. So one of the things that I've heard is that kind of preparation for individuals to work specifically impacting social and emotional well-being in infants and toddlers, and that is a possible, I see that as an area of perhaps another entry-level credential. And keep in mind that what we're doing is entry-level training. So the other thing you need to know, every technical college has a variety of programs that they offer. Early childhood care and education is one that every college offers, okay? So it's in all 22 technical colleges. In the academic year 2019, 5,591 students were enrolled in early childhood programs across the system, okay? So that was in a 1-year time period, and in that time period, that comprised almost 4% of our total system enrollment. So almost 4% of the students that were attending technical colleges were enrolled in early childhood programs. Just to give you a sense, and this really is not specifically about Chattahoochee Tech, but so that you understand our structure, most technical colleges have multiple campuses. At Chattahoochee Tech, for example, our early childhood program is offered on 3 of the campuses that we have. We don't offer it on every single campus, and we offer some of the content online. It is not a program that we offer completely online. Okay, so in terms of our graduates, our students graduate from programs throughout the year, any semester. In that same academic year, 2019, there were 97 students that earned that infant toddler child care specialist certificate, and that's the one. Tamika's going to give you more specific information about that certificate. It's 16 credit hours. In contrast to that, in that same time period, 204 students earned the Early Childhood Program Administration Certificate. And I don't really know what to do with that number except to say that we do see more students express an interest in going into program administration or going into working in preschools than we do students specifically saying they want to work with infants and toddlers. And that may be a variety of reasons, and we'll talk a little bit about that. And then the total number of associate degree graduates in that same year was 400. The other thing that's important to understand about what Chattahoochee Tech and the technical college system does is that our whole reason for being is to prepare the workforce. So our placement rate is extremely high. We're very proud of that number. So of those students, 97%, 97.9, almost 98% of them are working when they complete our programs. And to be fair, many of them are working while they are completing our programs. We have quite a few students who are working as early childhood professionals, and they are attending school while they're working. And what you'll see is that our graduates work in a variety of settings. So some of the settings that we've talked about today, they work in licensed child care centers, they work in the Georgia Pre-K program, they work in family child care programs, they work in public schools, they work in Head Start programs. So a wide variety of employment opportunities for early childhood care and education graduates. The other thing I want to point out, and a couple of the DeKal Scholars Program has already been mentioned. Tamika's going to talk a little more about that, but I do want to mention the Hope Career Grant, and you all may be familiar with that. So the list of programs that are high demand career initiatives. So those programs that are deemed really high demand in Georgia, early childhood is one of those programs. And so students who choose early childhood care and education are eligible for what's called a Hope Career Grant. Now, you're familiar with Hope Scholarship and Hope Grant, but Hope Career Grant, for those areas that have been identified as high demand career areas, students are able to receive that career grant on top of their Hope Grant, which actually bridges the gap and covers 100% of tuition in those programs. And that's a really big assistance for our students. One of the things I was just looking at numbers yesterday, and it looks like across the system, 65% of students in eligible early childhood programs are funded through the Hope Career Grant. So one of my goals would be for that number to be higher, and that may be, awareness of that extra assistance and that sort of thing. So I'm going to turn this over now to Tamika Brundage, who is our lead instructor in early childhood, and she's going to talk more specifically about DeKal Scholars as well as our curriculum so that you get a sense of what students who come through technical college system programs are learning.
Okay. Good afternoon. I want to say thank you for allowing us the opportunity to present what we do in reference of children. For the DeKal Scholars, a lot of our students are familiar. We place information in our classrooms as well as online. And we also have had Charlotte to come out to speak with our students about the benefits of this DeKal Scholar program, which allows for students to receive incentives, like an extra bonus, for them to receive higher education. And so as our students go throughout our program, they decide that they want to continue, and they start with the TCC Basic, which is a certificate that allows our students to receive credit for 3 classes, and these particular 3 courses is a entry-level incentive. And so they receive funding and they're super excited, and then they decide that I want to go further. And then that as they progress throughout, they may decide to add additional certificates or decide if they want to go into the diploma or degree, which as they go up and as they develop and go up into that particular program, they receive specific amounts of incentives that kind of motivates them to keep pushing forward in the field of early childhood. And beyond what we do as a program, students can receive these incentives also for bachelor degrees and master's degrees. So it's great to know that that work is in place. The next. In our early childhood education program, we love and we invite various industry workers to be a part of our, I would say industry experts, to be a part of our program advisory committee. With our program advisory committee, these individuals meet on a regular basis to tell us about the new trends that are taking place in the field and new developmental needs in which we take into consideration their thoughts and their their understanding of the field, and we incorporate ideas into our curriculum. And so that helps to impact the workforce. So some of the ideas that they bring to the table, we ponder over and we actually come to a consideration of how can we incorporate these particular needs that the industry is being impacted with. How can we incorporate this into our curriculum? And so their their expertise and their opinions really matter as it relates to what we do in the workforce. So we offer opportunities for Head Start individuals to be a part of our program advisory. We have one who is a curriculum coordinator, and we bounce around ideas about how we can incorporate some of the things that they're doing in Head Start. We also have a regional director from a chain of child care centers, as well as corporate child care centers who sit on our board. There are several center directors, owners, as well as ECE training managers from Quality Care who trains teachers, as well as they do a lot of support in the community. There's also a CTC, a Chattahoochee Tech student who sits on our board, because we believe not only is it important for the industry to have a say, but it's also important to see what our students have to say as they're going throughout our program, and what their opinions are and ideas that we can particularly improve on as it relates to our curriculum and our program as a whole. We also have pre-K and school-age directors who sit on our board as well, who also incorporate their ideas and understanding of the field. I am messing up. Okay. What students learn in our ECE program? Typically, they demonstrate understanding of child development, and they demonstrate how to create a healthy and safe environment for our children, and what it looks like to have the quality care in those child care centers. They understand how to assess children, and they understand how to use those assessment tools to plan for children's learning. They also look at how to support families, because they know once they go into this field of early childhood, those children are your number one priority, but that's not your only job. That is your commitment is also to those parents as well. So how do you support the parents as well as those children? So they learn about different strategies and concepts on how to work with those families. Advocacy is a huge talk as we talk about in our program. How do you advocate for those children? How do you advocate for the things that you need within your program? The context of quality, what does quality look like? We partner with programs that are NACE accredited as well as quality rated for our students to have that practicum experience as well as internships within our program. And I want to mention that for a total of our students receive a total of 300 field experience hours out in the field with children, which also increases as they go into the field and do some observations and things like that with partnering sites. And so 300 is a lot of hours spent in the field being able to work with these children as well as those cooperating teachers. One of the 9 certificates that Marcy mentioned is the infant and toddler certificate that our students can enroll in our program to receive. Within that, this particular certificate, there are 2 courses, one being 2330 and one being 2332, which has a total of about 65 competencies. And so those are 65 areas in which we actually focus on as it relates to infant and toddlers. As we go through 2230 infant toddler development, some of the areas that we cover focuses on ages of infant. So it focuses on looking at the developmental ages and the different characteristics that these infants portray during that time. They look at social emotional milestones. They look at the importance of brain development, some of the discoveries that happens during the infancy time frame. They also look at the language communication of those infants and as well as the adults. They look at infant and toddler with disabilities and how do they, how do you assess those, and where are the resources out there in our community to help those parents to receive assistance for those infant and toddlers? They also look at the socialization as well as the assessments and screening for infant and toddlers in this particular class. Now for ECE 2332, they have 22 learning outcomes. And within this class, our students focus on the philosophy behind the primary care for children. They also look at the routine, the caregiving, and the curriculum, family and community characteristics, the selection of materials that we use within the classroom of students. We look at also the inclusion. But I do want to point out for 2330, the toddler development, we have a specific area that focuses on social emotional development. One being that students are able to identify the 3 major temperament patterns. They recognize temperamental traits and their handling. They identify the stages of emotional development, that they describe babies' emotional milestones. They identify emotional strengths of their development, and they're able to describe how to get in tune with the infant and toddlers. They explain the caregiver's role in the child's development of self, and they're able to examine the importance of culture in early childhood development. These particular 2 courses are a total of 6 credit hours for our students, and they can receive this as a standalone certificate, and with the hopes of being able to bring quality to the early childhood field.
Well, and I also want to point out that certificate on that earlier slide, that's a 16 credit hour certificate. So 2 of the classes are these 2 that are infant toddler specific, and then the other classes in that certificate are the child growth and development course, the health, safety, and nutrition course. So those are always kind of, those courses appear in a lot of our different credentials. One last thing I want to mention in terms of workforce development and issues to consider. It's been mentioned before today, but turnover is an issue, and we see that with our students. We see them talking about someone left, I'm considering leaving, the stress level. It's interesting to me, and in my role now I hear from fewer students than Tamika does, but to see what students, potential students' perceptions are as they come in, and what their career aspirations are. I want to work with children. I want to be a teacher. And so what we try to do, one of the kind of cornerstones of our programming in the academic area is both academic advisement, we want you to get through your program of study, but also career advisement, letting students know what kinds of opportunities there are, both in direct and indirect care in the world of early childhood care and education, and what that might look like for them. So there are a lot of things, and of course salary and benefits is something that students are always talking about, they're interested in. So those are some of the workforce issues that face us on a regular basis.
Thank you. We do have a question, Representative Oliver.
Yes, ma'am.
Thank you. I assume you're tracking what programs are full, what programs are not being full, whether there's a regional disparity workforce, and that you can tell us, you know for your own interest, how many of your students move from an associate degree in early child to maybe a graduate degree to go to teaching. I'm curious about all that.
Correct. And we have a fair number of students who express an interest in starting at the technical college, and speaking specifically for Chattahoochee Tech, and then wanting to transfer on to do a teacher certification, to do a bachelor's degree. And we do track that for Chattahoochee Tech. I'm certain that every college tracks that. So our Office of Career Development keeps track of where students go. In terms of student programs that are full, I want to make sure I'm understanding. Do you mean in terms
Are you
of
at capacity, or do you have open slots?
Oh, in any given semester, we are very close to capacity in early childhood. And we have an interview this afternoon. We're hiring an additional instructor because we are always kind of monitoring that. It is at Chattahoochee Tech, it's one of our always in the top 10 largest programs, often in the top 5 largest programs. It's very popular. And we try to build capacity on our different campuses. We fill in with online. We don't feel comfortable offering it completely online because there's some of those hands-on things that students in early childhood need to learn. But there is content that we also offer online. Yes, ma'am.
Thank you.
Okay. I think that's it. Thank you so much. Thank you for
Thank
the
you.
great offering that you're making at Chattahoochee Tech.
Appreciate it.
Appreciate it. All right. Now I know we're in for a treat. We're going to hear from the commissioner, Amy Jacobs from DeKalb. Commissioner Jacobs leads the agency responsible for the early care education of hundreds of thousands of Georgia's children. She oversees programs focused on child care licensing, child and adult care nutrition, child care quality, early childhood education, and specifically Georgia's pre-K program. But I know she is deeply involved in so many more things than that because I see her just about everywhere. Thank you, Commissioner, for being here and for sharing with us.
Thank you very much, Madam Chair and members of the study committee. I apologize that I could not be here yesterday. I'm the chair of the Deal Center for Early Language and Literacy down at Georgia College, and we had a board meeting. So I'm sorry that I couldn't be here, but I appreciate the invitation to speak with you. Very briefly, because I know you've heard a lot over your several weeks of study. First, I want to say thank you for studying this important issue. There has been a lot of valuable and rich discussion and even budget and policy enhancements around mental health needs for adolescents, teens, and adults in recent years, but nothing specifically for infants and toddlers. And I think just from my perspective, we've all been scared to talk about what are mental health needs for infants and toddlers? Do we really know what we're talking about? And just from trying to go back and look at some of your meetings, I feel like you've really gotten the gist of what we mean by infant and toddler social emotional health. And I know you've heard from many experts over the last several weeks about the science, the research, the services, and the real-world experiences, especially from child care providers for infants and toddlers and their social emotional health. I know yesterday you also heard from Susan Adams, DeKalb's Deputy Commissioner from Pre-K and Instructional Supports, and I trust that her presentation and her panel participation provided insight into the services that DeKalb provides to child care programs, teachers, and children as it relates to social emotional health for infants and toddlers. So I will be brief, but I wanted to take the opportunity, since it was offered to me, to highlight DeKalb's role in supporting infants and toddlers. So DeKalb is uniquely positioned to support child care programs, their teachers, and their children. We are statutorily required to license and monitor all child care programs to ensure the health and safety of children in their care. We license about 4,600 child care programs all over the state, and they serve over 337,000 children each year. And our role as a regulator has grown over the last several years and transformed to not only providing oversight and monitoring, but also providing support to child care programs. And we do this in several different ways. One is through grants and professional development. You heard a little bit about PBIS and SEEDS grants. We support early childhood educators in supporting children's social emotional health. This centers around responsive caregiving, allowing infants and toddlers to establish a strong, secure relationship with their caregiver. These secure relationships allow children to develop trust, regulate and express emotion, explore and learn. Developing these secure relationships with caregivers and with others is crucial for the development of healthy social and emotional skills in infants and toddlers and lays the foundation for good mental health, lifelong learning, and success. We also provide supports and training to child care programs when they are dealing with children with challenging behaviors. In fact, the number one call we receive from providers is asking for help with children with challenging behaviors. Because as much training as our teachers receive from either the Technical College System of Georgia, through the University System of Georgia, or wherever they may receive their training, they are not equipped to deal with children with challenging behaviors. They do not receive that training on a regular basis. So due to that demand, we recently expanded our inclusion staff to include 18 individuals. Some are behavior specialists, and some are inclusion staff to work with child care programs and teachers. They provide coaching and professional development to strengthen social emotional support in classrooms and to reduce challenging behaviors. We've also created a helpline so that child care providers, teachers, parents can get help in their classroom or for their family. We hear a lot from desperate parents not knowing what to do. They know that their children might need a special service. They know that their children might need a different type of child care environment, and they can't find it, and so they call their helpline. And this helpline has helped us to triage the needs that often outpace our staff capacity. And we've also adopted and provided an immense amount of training and free classroom resources around the CDC's Watch Me Grow. This is a developmental milestones and monitoring program. So while child care teachers do not possess the qualification to conduct developmental screenings, this tool allows them to conduct surveillance on developmental milestones and then share those concerns with parents so that immediate follow-up with the child's pediatrician can take place. That falls into the early detection phase. These teachers are with these children 8 to 12 hours a day, 5 days a week, and when they can watch through those developmental milestones, if they're not meeting those developmental milestones, they can use this tool to then work with the parents to get them a referral to their pediatrician. So although we've increased our supports to child care programs, there are limitations to what we can do. DECAL plays a critical role in supporting strong social emotional health for infants and toddlers, but our services and our supports we provide are confined to licensed child care. And while that reaches 4,600 child care programs and 337,000 children, we can't reach them all, which is why we have the hotline. And there are children that are not served in licensed child care, so we would not reach those children that might need services. And our role is to support child care programs. And we have hired and trained our staff to do that, but oftentimes that need outweighs our staff capacity, which is one reason we created that helpline to help us triage and prioritize and then refer to services that we cannot provide. And again, we cannot provide intensive mental health, direct mental health services, and in those cases, we refer to Babies Can't Wait or preschool special education, depending on the age of the child. But for those reasons, I will say to you as a study committee, that is why I truly believe our state needs a comprehensive, reliable, consistent referral process and services so children and their families get the services that they need, and I'm hopeful that the study committee will be the catalyst for this change. Thank you, and I'm happy to answer any questions.
Thank you so much. I believe Representative Oliver has a question.
A comprehensive referral service has to result in services that are being paid.
Right. You're right. And that's the challenge that we have. You know, there's only that small population of children that need those more intense services, which we can't provide. And the frustration that we see from our inclusion specialists is we can get the referral, but then there's nowhere for the services to occur.
And that's what we need help on. I don't know if I'm talking for we, but I want to know exactly where the money needs to go, to whom, at what kind of rate, payable by whom.
I wish I could answer that question.
Well,
I would love the answer to that question too, and we're happy to be at the table to talk about the types of issues that we encounter at DECAL. I've always been under the impression that that's a Babies Can't Wait or preschool special education. That's who we refer to. But then again, it's this, we hear the same thing. They don't have the workforce, or they can't recruit the workforce because the payment is not enough. So I do think there needs to be some intensive, deliberative discussion on what are the real issues that we need to address, how do we get the workforce to support it, and how do we pay them?
how do we pay them? When I was appointed to this committee, I thought, well, I know something about that. But every week that's gone by, I realized that I cannot figure out what the money flow is from Medicaid for these children, consistent with the EPSTT and consistent with Babies Can't Wait. So you're a good person to figure that out and tell us.
Well, if given the charge, I would do my best, because we're frustrated on our end. I think a lot of parents and families are frustrated. We would love to figure that out, and I think it just takes a lot of honest conversation, talking about what are we really talking about, what types of services do these children really need. It's, you know, when you think about adults, they need very intensive services if they have very intensive needs. Sometimes children just need occupational therapy or physical therapy or speech therapy, and they should be able to get that through Babies Can't Wait, and when they age out, they should be able to get that from preschool special education. But I think that's inconsistent throughout the state.
Thank you.
All right, that's the only question I see, and part of that is because there has been a lot of good work and information
Absolutely.
brought to us. But as we continue, we have one more meeting that I think is going to be pretty intense as well coming up. So if you think of anything else, Commissioner, that you need to share with us, please don't hold back.
Okay.
Any ideas to talk about, even offline, if we
Okay.
need to try to. 'Cause
Absolutely.
the goal will be to come up with a very good report, I think, that puts forward some real proposals.
Well, we look forward to working with you on that.
Thank you.
Thank you.
Thank you so much. Thank you. Okay. So, I know that we're running a little bit, we're not late, we're still in our time frame, but we're going to be a little late for public comment. So I'm going to ask today if there's anyone here to make public comment. If you would just raise your hand, we want to take your name down for sure. I don't see any right now. Am I missing anything? Okay. So that's kind of a good thing, Callan. That allows you to, and it was going to anyway. We were going to kind of put that forward. We will probably have to leave the room right at 1 or a few minutes before because there's another very important study committee coming in here at 1 o'clock. But I do want to ask Callan to come forward, please, and to Callan Wells, the health policy manager for GEARS. Callan is going to give us some specific recommendation of the Georgia Infant Toddler Coalition's Infant and Early Childhood Mental Health Committee. The committee is comprised of child-serving professionals, advocates, many of whom you've heard from throughout our previous meetings as well. Thank you.
Thank you. And I didn't even look at my clock, so I don't know if it's afternoon yet. But good morning or afternoon. Thank you to Chairwoman Dempsey and the committee for having me today. I'd like to start by commenting on how enjoyable it has been to watch this committee. I think I can speak for all of us who have followed along in commenting on the openness with which you all have received this deep and sometimes heavy content. As Chairwoman Dempsey has requested at the start of each convening, you've all come with an open mind and heart to this task, so thank you. Again, my name is Callan Wells, and I am the Health Policy Manager at the Georgia Early Education Alliance for Ready Students, or GEARS for short. Our organization seeks to promote policies that ensure children birth to age 5 have access to high-quality, affordable early education, as well as the right environment in which to develop into healthy students ready to learn when they reach kindergarten. To that end, GEARS convened the Georgia Infant and Toddler Coalition. This coalition works together to specifically address the needs of the state's youngest children, those under age 3. The coalition consists of many community partners, including childcare providers, pediatricians, infant mental health therapists, and other professionals who work with young children and their families every day. We also have consulting members from many of the child-serving state agencies who do not contribute to our advocacy efforts but inform us as subject matter experts. Over the last few years, it became apparent to the coalition that infant and toddler social emotional health needed to become a key priority. Our coalition members continually brought up the issue of preschool expulsion, which we've talked a lot about, which happens at a higher rate than K through 12 expulsion. As we heard yesterday, 2, 3, and 4-year-olds are expelled at a higher rate than their older counterparts. Our coalition members recognized that behavioral issues were commonly the cause of these expulsions, and upon diving deeper, came to understand that for a little kid, behavior is an indication of their social emotional state. The coalition decided to form a committee that focused primarily on the mental wellness of infants and toddlers, thus forming the Infant and Early Childhood Mental Health Committee. I'm here today to give you the recommendations from that committee. Again, this committee is comprised of those professionals who work with children and their families most. Many of the speakers you've heard from over the course of this study committee are members. First, we'd like to recommend the formal recognition of DC 0 to 5, the diagnostic classification for young children you've heard about many times throughout the course of these meetings. DC 0 to 5 allows for practitioners to give a developmentally appropriate diagnosis to young children. It recommends that all practitioners consider a child's relationships when making a diagnosis, gives recommended actions for a treatment plan, and when coupled with a crosswalk to ICD-10, gives a practitioner a clearer pathway to billing for their services. Tennessee, for example, has already developed a crosswalk between ICD-10 and DC 0-5. That brings me to the next recommendation, and one that I think we've all been talking about throughout this committee. The ICMH committee recommends that Medicaid, Peach Care, and the CMOs clarify billing codes to include social emotional health screenings for young children, dyadic treatments such as child-parent psychotherapy and parent-child interaction therapy, and parenting programs such as the Incredible Years and Circle of Security. Arkansas has already adopted similar codes if a state precedence is needed. Our next recommendation is to develop a cross-agency leadership structure that focuses on infant and toddler social emotional well-being, so that the state agencies currently working in this area can coordinate and align efforts. Many other states, including Alabama, have created a similar structure for infant and early childhood mental health, and our state has examples in different areas, such as the interagency directors team led by DBHDD. And last, we believe a concerted effort needs to be placed on developing a workforce and referral network for practitioners in this field. We've heard from many experts today on how this might be done, and we recognize this will be an ongoing conversation to come up with a Georgia-specific solution that impacts the full range of services from promotion to prevention to intervention to treatment. Again, thank you for allowing me to speak today, and please let me know if you have any questions.
Do we have any questions?
I didn't understand the initials of your first, that you said DM, I couldn't quite get the initials.
DC 0-5.
Okay, say that again.
So DC 0-5 is the diagnostic classification for children 0-5. It was developed by 0-3. Jamie, who spoke during the first meeting, Jamie Colvard, talked about it and brought her copy. Both Tracy and Kathy, when they talked, had their copy. It's sort of the integral, the text that's most used, the DSM for young children. But it allows for developmentally appropriate diagnoses. Oftentimes, I think this is one of the sort of issues that many practitioners face when they are going to bill, is that there's no diagnosis for young kids. Because they're not supposed to provide a diagnosis until a child is older. So this allows for developmentally appropriate diagnoses, and then that crosswalk to ICD-10 could allow for ICD-10, and
Okay.
I have no idea what ICD stands for. I'm so sorry, but it's the way that Medicaid codes diagnoses.
Thank you.
Yeah,
I got it
thank
now.
you. Thank you so much.
Well, thank you. Thank you for boiling that down very succinctly for us with some very good proposals. I appreciate it and greatly appreciate all of the work that you have done to help bring us through this process. And we're not through. We will be back. There will be a fifth meeting. We're looking at the date and kind of seeing who else we need to hear from, what is missing. Some issues that may still be a part of the committee would like to see and hear answered, and more discussion on this. This has been a profoundly good day, another profoundly good day. So I thank y'all so much. And as I'll ask one more time, is there anyone here to make public comment on the Infant and Toddler Committee? I know there's another committee coming in, and we want to give them the space and the time to get ready for another very important discussion that affects our infants' welfare as well.